1 sequence. I've done this because you guys know a lot about anatomy already, so I don't need to go into quite as much detail. I've taken out quite a lot of the studies. If you do want more of the information on the studies, please let me know as we go through, and I'll send you the pre-reading that I send to all my clients who do my level 1. So if you'd like more of the sciencey geeky stuff, I can send you it. So hypopressives, it's a holistic way for us to treat the pelvic floor and pelvic floor dysfunction. This on the side, so the picture here is here for a really good reason. When we see the apnea breath or the special breath done on the internet, we usually see the versions that are in the middle here. So either the middle screen, so any of those across the middle. All of these, however, are really good apnea breaths. The widening of the rib cage creates a drawing inwards and upwards of the abdominals. In some people, it's more dramatic than others. And this is because of body weight and because of rib cage size. So it's to do with the dimensions of your body rather than you either effectively getting it. Each one of these is a really good apnea for that person and in that person's body. So always with my clients who come, they're like, oh, my apnea doesn't look like the one I've seen Trista do, or I've seen so-and-so do. And I'm like, well, it's your body's your body, and it will look different. So making sure that we don't get hung up on what we see and we're more into what we feel going on in our body is really important in hypopressives. Although there are some telltales that I'll teach you about so that you can see that things are going in the right direction. So we use a combination of postural awareness, breath work, fascial mobilization, nerve flossing, and tensioning. So it's more active stretching than tensioning. There is a little bit of tensioning of nerves, which I'll talk you through when we do it, so you know what I mean by tensioning. There's also muscle chain activation and also visualization, which is really key sometimes to encourage the pelvic floor to begin to mobilize in a functional way again. The aim, which is weird, is to almost forget about the pelvic floor, focusing in on the other members of the team to start with, weaving the pelvic floor back in through visualization and awareness later. So I kind of want people to just not think about their pelvic floor when we begin. Okay. The benefits. So these are some of the benefits that people feel and have been shown in studies, not so much in the UK. The studies have been done in Canada and in Spain and in Belgium, and less here in the UK so far, although there are some starting. So it enhances posture, alleviates back discomfort and strengthens the core muscles, promotes a balanced resting tone, and that's important that we're looking for resting tone rather than tightness, enhances lung capacity, boosts athletic endurance, enhances intimacy and sexual satisfaction, which cannot be overlooked, promotes a functional pelvic floor, reduces anxiety and stress, and improves lymphatic drainage. So the history, a little bit of history, the history of hypopressives. A lot of people will see the hypopressive maneuver or the unique breath that we use and think that it's very much like Uddiyana Bandha or Nauli that we see in yoga. So oftentimes people will come to me and they'll be like, oh, I know how to do it because I do yoga and it's the Uddiyana Bandha. The difference is between what we do and an Uddiyana Bandha is the Uddiyana Bandha is a lock to tighten and control the thoracic area of the body, and is often taught as a drawing inwards and upwards of the abdominals after a forced exhalation. It's then held in place. We're going to learn how different the breath work is in hypopressives, and I'm going to talk you through it. But we're going to have a look at an Uddiyana Bandha first so you can see, and then I'm going to talk through the difference. The bandha is usually done with a throat lock too, which is a jala, and is often only performed standing or sitting. So it's not performed in different postures or different poses. The benefits are really similar for hypopressives though that we get with Uddiyana Bandha. So there's similar benefits. It strengthens the abdominal muscles and diaphragm, massages the abdominal viscera, the solar plexus, the heart and the lungs. And this is through the movement of the diaphragm primarily. Increases gastric fire, which improves digestion, assimilation and elimination of toxins, and purifies the digestive tract. It also stimulates blood circulation in the abdomen and blood flow to the brain. Now, the thing with hypopressives is it also stimulates blood circulation in the pelvic floor too, which is why my clients who come to workshops and things will send me messages going, I had the best sex last night, because which is quite often what I get back, because it's much more stimulation and blood flow to the pelvic floor. It also stimulates and lifts the energy of the lower belly, and energizes the navel and heart. So if we're thinking about chakras and energy lines, we're working with an energy line all the way through our body too. So I'm going to show you it so you can have a look at what it looks like, just in case you haven't seen one. So the abdominal, the Nowley is a lock. What we're trying to do in hypopressives, or what we do in hypopressives, is we're wanting to engage through fascia chains and through muscle chains. We're not wanting to create a lock anywhere. We want to create a gradual widening of the rib cage when we come to do it. And that gradual widening of the rib cage starts to stretch, create an active stretch through muscle chains, but also creates a transfer of pressure in the thoracic area. So we are doing a few different things than they're doing during the Uddiyana Bandha. The first real hyperpressive style rib opening is with Bruce Lee and Arnold Schwarzenegger. So the abdominal vacuum has been used in abdominal training and bodybuilding for a really long time. The action of creating a vacuum through the use of the expiratory breath and then a costal opening can be used to show the definition of the surrounding muscle groups, which is why it's used in bodybuilding. But with the difference between the bodybuilding is that they're not got that focus on the breath work to start with, or the focus on the poses that are going to actively engage the muscle and fascia chains that we're looking to engage. But these are also a vacuum. So the same, in a similar way to the way we teach it. So the bodybuilders who come to do courses with me are really usually have already experienced the apnea the way we do it. The apnea can also be used to tone and strengthen the deep transverse abdominis muscle, which I will talk about in a bit, and also the obliques, because the obliques are really a big part of this, along with the serratus and the diaphragm. The next part of our history is Dr. Kegel, who was an amazing guy for his time. He spent 18 years studying the pelvic floor and trying to come up with something that would really help women. So after his 18-year-old study, he brought forth his findings that women and men could activate and strengthen their pelvic floor through a series of squeezes, differing in intensity. But even he didn't think that just telling women how to do them would work, and he invented his Kegel pyrometer. It's a little like a Kegel 8 is today. I'm going to show you a picture of that. So, brilliant. You know, we're like, yes, he solved the issue of pelvic floor dysfunction. The issue is that quite often Kegels are embarked on by women with very little or no clear instructions. This leads to muscles we are trying to get to being overlooked as we recruit our hip abductor muscles instead, abdominals and glutes. So oftentimes women will, and men, will realize they've got an issue, and then what they'll do is they'll look up Dr. Google and they'll look at Kegels, or they'll be given Kegels by their physiotherapist but not taught how to do them, because especially in the UK, you're given exercises to do with a sheet of paper and sent away to do them. It's different in France, because in France they have, most of the time, it's not everybody actually, but in Belgium too, a lot of the time, they have, they can get checked by their physio after they give birth. So they get an actual, the physio actually checks that they're releasing after they tighten. But what happens in the UK, and for most people who just Google and find exercises to do online, is that a lot of women and men are holding an incredible amount of tension in their pelvic floor before they get started. So they have tension holding patterns already. And then what happens is they take their already tight muscles and they tighten them. And then when they do what they think is a release, they only take it back to tight, so their tension pattern, and then they tighten again. So initially, they might feel that their condition is getting better and their pelvic floor is getting better. But over time, those muscles will get super, super tired. And when they get really tired, they'll just stop working altogether effectively. And the reason it takes so long for the pelvic floor muscles to get tired is because the pelvic floor is mainly made up of slow twitch muscles. So slow twitch muscles take longer to tire and also longer to fire. So what happens is we just have, what ends up happening is other muscles start taking over for the pelvic floor. So, and we'll talk about that in much more detail as we go through, like the hip adductors, the abdominals and the glutes as well. Do you have any questions about Kegels or any of this sort of thing? Okay, I will move on. So the big granddaddy of hyperpressives as we know it today is Marcel Caffrey's. Marcel is still around, but he began looking at this in the 1980s. And he observed that the pressure exerted by the thoracic diaphragm together with a weak parietal resistance were the cause of vaginal hernias, so prolapses, urinary stress incontinence. So the parietal area, the weak parietal area, is the whole area of fascia that surrounds the abdominal viscera. Likewise, he discovered the antagonistic postural relationship between the serratus anterior and the thoracic diaphragm. So there is a real correlation between what happens with the serratus anterior muscles and what happens with the thoracic diaphragm. And it's the serratus anterior, that we're going to be using primarily to help widen our rib cage, to help with the extension of the thoracic diaphragm when we have no air inside or residual oxygen inside. So you notice that when tension in the serratus, a thoracic expansion was provoked, while a tonic relaxation of the thoracic diaphragm causing a decrease in intra-abdominal pressure. And it's that decrease that we're going to play around with, or we're going to play around with pressure in our whole abdominal, our whole torso area. So that's what we're going to be primarily playing with. In this way, the beginning of hypopressive techniques emerged, defined in the program he calls it diaphragmatic aspiration techniques. He actually first discovered that he was onto something because he was doing an internal examination and his hands were really cold. And when he went to do the internal examination, the woman made a weird noise and did something with her rib cage, and her prolapse disappeared up inside her. And so that's what started him on the process of trying to work out what happened. And these were his findings. He took, and low pressure fitness and the way that hypopressives have taken things from other experts in postural techniques as well. So one was Françoise. So Françoise discovered that certain muscles intertwine. So this is where the idea of muscle chains comes from, resembling tiles on a roof, creating what she termed muscular chains. These chains harness remarkable collective strength, the cumulative power derived from each individual component. It is this formidable force that leads to distortion, stiffness, joint immobility, compression of invertebrate discs. In essence, our musculoskeletal issues and poor posture stem not from muscular weakness, but from compression forces generated by the persistent contraction and shortening of our muscular chains. So in hypopressives, what we're always looking for is this continuous active stretching. So making sure there's space between the joints, making sure there's space between the vertebrae. And this is super, super important to the practice that we do. So we're not looking to try and tighten anything, but more elongate and lengthen. So Mesure's developed method employs innovative and nuanced neuromuscular techniques, incorporate distinct postures that are really similar. Honestly, they're quite similar to Pilates ones and very similar to hypopressive ones. A specialized breathing approach, so she looked at diaphragmatic breathing, three-dimensional breathing, but without the apnea, and hands-on interventions from the therapist. So being manipulated into positions or encouraged or shown positions in your body by the therapist. The primary objective is to reduce the surplus muscle tension, which is what we're also trying to do. We're trying to take away the muscle tension, consistently present in muscular chains because of posture patterns we develop. This reduction facilitates the body's transition towards a significant enhanced shape and posture. Consequently, musculoskeletal issues causing pain tend to fade away. Additionally, there's a beneficial side as weaker muscles like those in the abdomen and the front of the thigh naturally gain strength. And this is really important because a lot of people's posture patterns with their backs, it means that their back muscles and the whole back area is incredibly tight in either a kyphotic or a lordotic position. And that's where a lot of my clients find themselves because of the tension patterns they employ to help their pelvic floor. And we're going to look at them. I'm going to get you to try them out and see how they feel in your bodies. So the other one is Philippe Souchard. So he is a French physiotherapist, and he came across another system which we also use. He saw that injuries came from repetitive movements inherent in daily tasks, as well as demand from work and sports activities that necessitate prolonged postures. So think sitting at a desk, driving in a car, kids on their mobile phones. He said that these contribute to the shortening of muscle fibers. So again, we're looking for this lengthening of muscle fibers, rendering them less amenable to stretching. This muscular retraction impedes fluid movement. And this was really pre-fascia, but he's already talking about the fluid movement that we now know, and we now have seen pictures of, and we can see videos of how moist the fascia is and how much we need that fluid. And if we contract muscles and hold posture patterns, our fascia becomes dry, and it's that lack of fluid and movement through the fascia that can create pain and impede movement. So he was already onto this in the 1980s. The ensuing consequences include pain, inflammation, joint compression, restricted range of movement. So to address these issues, he offered a unique and dynamic approach to musculoskeletal rehabilitation, which looks really similar to the poses that we use in hypopressives. So the hypopressives is a combination of lots of different things that have been drawn together to create a method that's amazing for creating better postural choices, better breath choices, and also a more functional pelvic floor. Any questions about all of that? These are people that if you're interested in the anatomy of where things come from, they were big movers and groovers. This is a picture of Francoise addressing the distance between the iliac crest and the rib cage, and we're going to talk about that because it's one of the fundamental principles of hypopressives. And this is one of the poses really similar to the poses that we used in hypopressive, which Philippe Souchard used to use as well. Okay, so low pressure fitness came out of Pitty trained with Marcel. And Marcel will not train anybody, no matter how great you are at working in women's health and how great you are as a movement specialist, he will not train anybody who is not a physiotherapist. So you have to be a physiotherapist to do his courses. I know because I tried and he wouldn't let me in, you know. So I found Pitty after that, and low pressure fitness as well. Pitty was a physiotherapist and a movement specialist, and he'd already been really big in the idea that sit-ups and things were not great for women postnatally. So there was a big thing called Abs Stop the Massacre back in the 1980s, and he worked to develop the way hypopressives the way they are into a more movement-based practice. So Marcel, when he teaches it, they're very static, active stretch positions. There's not the mobilization that we learn in the dynamic part of this course in part 2, and we do a little bit of it in part 1. Tamara was doing her thesis on women's health and sports fitness and breath and all sorts of other things, and then she diverted it to hypopressives, and she used this as her thesis for the end of her studies. And then her and Pitty created low pressure fitness and the mobilization of the poses that Marcel had. And she's added loads and loads of depth and science and studies to it as well, and they both have. And from out of that now, with the IHC, with us, we have so many other skills. There's trainers within the IHC, we have trainers from all over the world. And within that, we are developing hypopressives even further, bringing in things from gymnastics and things from water therapy and things from physiotherapy, and we're constantly evolving it. And even Pilates now as well. So there's bits that we're bringing in to make a hypopressives even more kind of a global modality. So that's what we're looking for. So yeah, that was a bit of a longer explanation than was written on your screen. Sorry about that. So yeah, and I've talked about the Hypopressive Council already. So yeah, and we would like hypopressives to not just be standalone, but to also be able to be moved into other modalities. So absorbed into Pilates, absorbed into yoga, so that the principles that really help women to create a functional pelvic floor can be everywhere. So you can do this as a standalone hypopressive section in a class, or you can use the core principles and adapt them to what you do. We're not, we just want better functional pelvic floors for everyone. So we're going to learn about different patterns of breathing in a moment. I'm going to come off the screen for a minute, and I'm going to stop the share just for a minute. And so I would like you all, just for a moment, to bring awareness to the way that you breathe just now. So we're going to just take a couple of minutes for this. And I'd just like you to take the time to just breathe to start with. And as you start to breathe, and don't think, oh, I've got to breathe a certain way because Abby says, or I heard Abby say this, or somebody said this. I just would like you to just tune into the way you normally breathe. So maybe think about a song that you know really well, and think about that song and start breathing. And that way we're not going to be thinking too much. And I'd like you to think about which parts of the body you primarily use when you breathe. What moves first? What moves last? And as you breathe, I'd also like you to bring your attention to your neck. How does your neck feel? And I'd also like you to bring your attention to your mouth and your jaw. How does that feel? And I'd also like you to bring your attention to your hands. Are they relaxed? Are they tense? How do they feel? Okay. Now I'd like you to take a nice big breath and feel what moves when you take a really deep breath or big breath. Okay, so now we're breathing like this. This doesn't always work with clients. This works with my clients much more. So while we're breathing like this, I'm going to do a timer, and just your natural breathing. So I don't want you to overthink this at all. And I would love you, I'm going to give you a 30-second timer. And I'd love you just to count how many breath cycles you have in 30 seconds. So a breath cycle is an inhale and an exhale. So just start now. And I'll tell you when to stop. And stop. Now, whatever number, there you got my tune, whatever number that you have, multiply it by 2. And that's how many breaths you have a minute. Okay, so I guess we can use fingers, or you can put it in the type box, or however you want to do it, or you can shout it out. How many breaths did you have a minute? Or I can just go through you and just ask. You can unmute yourself. 18, okay. Carrie's got 18.
14.
12.
10.
8.
Okay.
I had 14.
14.
14.
14.
14, okay. Loads of 14s. 12s.
8.
Okay.
10.
So ideally, we're looking for about 12 breaths a minute when we're just sitting, not doing any activity. And we're looking to have definitely the high, on the high scale is when you get 20s. So we're looking to try and reduce that breath so we have about 12 a minute. And that's like a nice, calm, regular breath. So a lot of my clients, when I first meet them, have 20, 24 breaths, especially ones who are apical breathers or upper chest breathers. The ones who belly breathe tend to have it on a bit on the lower down scale, but a lot of my ladies that I meet who are chest breathers, we have much, much higher scores. So we're looking in how hypopressive. This is a great fun thing you can do with clients when you first meet them, and then you can revisit this 6 weeks later and see what the change is. And the change is usually pretty dramatic once they really learn how to use their diaphragm effectively. So How many of you discovered that you were belly breathers when you did that exercise before? How many people moved with their bellies first? Wendy? And how many people used kind of their upper chest area? Okay. And how many people initiated the movement with their rib cage? Good. Okay, cool. Okay, so that's the majority of ribs here, which is great. The majority of people that you meet in day-to-day, everyday life are either upper chest breathers or belly breathers. And most people completely bypass their rib cage. And we're going to discuss why it's so important that we do use our rib cage. But well done, everybody. So it's a little bit of a fun interlude. I'll go back to talking about the different types of breathing just next. I'm going to go back to our share, which is this one. I think we're on, yeah. Okay, so we're back here again, hopefully. Breathing. The apical breath, which is the upper breath breathing, upper chest and neck movement. So upper chest and neck movement, what happens here with my clients who have upper chest and breath movement, they come in, they're breathing like this, and I'm like, do you get sore neck? And they're like, yes. And I'm like, do you have a tense jaw? Do you grind your teeth? Do you have to wear a thing at night for your teeth? And they're like, yes, how did you know? This upper chest breathing loans itself to so much tension in the face and the jaw. And what's really important to know about that is if they've got tension, and this is why these are important exercises to do with people, if they've got tension in the jaw and they teeth grind, then it is almost 100% likely that they will have tension in their pelvic floor. So tension in the jaw and the neck area generally relate to tension in the pelvic floor. And these women who have tension in the pelvic floor, who come to me and they say, I've been doing Kegels for ages, they're totally not working for me. The reason they're not working for these women is because these women are already coming from a tense or tight pelvic floor. And we talked about that, or I talked about that earlier, that they're literally going from tension to tension to tension to tension consistently until their body's just knackered. And so it's really important for us to find ways, which is the breath work that we do in hypopressives, to find ways to release their jaw. They'll also have amazing scalenes. They've worked really hard to get these really strong scalenes. And so you can really tell people who really do like lots of upper chest breathing because they're using their secondary breathing muscles primarily and not their primary breathing muscles. So they tend to have really designated great breath muscles, but not the ones we should be working with. Why this is so important, so a lot of people, when we come to the breathing section of this, where we're talking about the breathing, is that you read all these breathing books these days, and they all say you must breathe in through your nose and exhale through your nose. Your mouth is just for eating. A lot of them, like breath technique books, talk about this. But for us, when we're talking about women who hold or men who hold an excessive amount of tension in their jaw, what we need them to be able to do is release their jaw. And if we teach them to do that through the breath work initially, then they get used to holding a relaxed jaw, and this takes the tension away from their pelvic floor. Afterwards, when I know that they can keep a nice relaxed jaw and they're no longer grinding their teeth at night and they're no longer getting into these tight jaw positions when they're thinking, then what we can do is we can bring in nose breathing. So we have two options for the breath when we come to do it. But initially, God, I hate when it does it. We want the release in the jaw to create the release in the pelvic floor. The two are so interconnected. So the diaphragmatic breathing that we're going to be looking at, our diaphragmatic breathing, is going to be engaging the diaphragm muscle, the intercostal muscles between the ribs, and the neck muscles. So we're going to be, it's between the ribs and the neck, it should be, because we've got intercostals that come at the back here as well, that attach into our spine, and also at the lower bit here too, below at the bottom of the spine too, on the bottom of the rib cage. The diaphragmatic breathing we're going to be doing is also really engaging the serratus. So we're going to have this connection between the serratus, the rib cage, the diaphragm, and so much more. The other breath that sometimes I see, I don't see this as much as the other ones, is paradoxical breathing. So I'm going to get you to try this one because it's a tricksy one, and this one's really hard to break the habit of. I actually met a woman at parents' evening, and who I've taught years ago, and she was like, every time I see you, I think about my breathing. I still can't do it right. So she's like really stuck in this paradoxical breathing pattern. She's never got out of it. So this is when the chest is going to expand during your inhalation. So you're going to inhale, and the chest is going to expand, but your abdominal area is going to draw inwards. And then during the exhalation, the abdomen is pushed outwards. It's not pushed outwards very much, because quite often with paradoxical breathing, they draw it in and they kind of keep it in, and it's almost like they keep drawing it in the whole time. So you're going to inhale and widen your rib cage, or breathe into your thoracic area here and pull your belly in. And then exhale, close your rib cage and push your belly out. This is a paradoxical breathing pattern. So what we're doing is we're mismanaging the pressure in our body, and we're going to talk. It feels really it's really uncomfortable for most people to do, but it gets really comfy for the clients that have it. The next breath pattern that I see a lot is belly breathing. So this is when the ribs are essentially bypassed and the lungs push down into the diaphragm, and the pressure is pressed out into the linea alba. When I see clients who do this, we talk about the muscles in the abdominal, in the abdomen and the back, and then I ask them which muscle is actually designed to push out just primarily to the front, to have no activation anywhere else. And the answer to that question when we come to it is none. All our muscles in our abdominal area are designed to work in conjunction with the rib cage. So when our rib cage widens, our transverse abdominis muscle attaches from the solar plexus all the way around the bottom of the rib cage. It attaches to the top of the pelvis. So as we inhale, what we're looking to happen is for the rib cage to widen, and as it widens, the transverse abdominis also widens with it, like a corset widening, and that all the way around. So not just to the front, to the sides and the back. And as we exhale and close our rib cage, the transverse abdominis closes like a corset being tightened all the way around. So we have this beautiful, every time we breathe, we've got this inhale that's widening and exhale that's contracting. And what we're essentially doing is managing the pressure in our body. As we're increasing the pressure, we're creating more space for the pressure to be dissipated around. So this means that the pressure is managed during the breath cycle. We're also getting an amazing engagement of the muscles as well. So we're really working the deep transverse muscle, which is helping to create a much stronger core and helping to support the spine. At the same time as that is happening, the obliques are also moving. So your obliques also attach to your rib cage and come all the way down towards your pubic symphysis. So as we inhale and widen the ribs, the obliques are stretching, and as we exhale, they're contracting back down. So we're getting a really lovely workout for the muscles that help to support the connective tissue of the linea alba. The other one is the oh God, I'm going to forget the name of it again because I'm terrible with names at the moment. It's our chocolate box. I'll come back to it in a minute. So the muscles that come down here, oh my God. So I hate my brain at the moment. So what this muscle group, which is surrounded by lots of little raphe, lots of little connective tissue that gives you that kind of popping out look like you've got a six-pack. What that's designed to do is designed to create that active tensioning between the solar plexus and the pubic symphysis. So it's also not designed to push out in front. It is designed to widen when we're pregnant, but so to give us space for the pregnancy. And it is supposed to be there so we can twist and move, but it is not designed to primarily just push out in front. It's also there as an active tensioning. So there isn't a single muscle in the abdominals that is designed to push out towards the front. Everything is designed to work as a system together. So as we inhale, we're looking instead to widen the rib cage to create that better space for the pressure to be managed. So let's try both of those. So let's try a belly breath. You're not going to move your rib cage at all. You're going to keep your rib cage nice. I heard this and I went to a breathwork thing with a yoga teacher who I love. And she was like, just keep your rib cage nice and still and breathe straight down through your diaphragm into your belly. And I was just like, all these women with dodgy pelvic floors. So try it. So try and keep your ribcage as still as possible and just breathe straight down through your diaphragm into your belly. And I'd like you just to feel how that feels in your pelvic floor when you do it too. Good. And then I'd like you to take your hands and put them around your rib cage. And I'd like you to think about your rib cage widening, like it's widening all the way around, the front, the sides and the back. And take a nice deep breath in. And think about the fact that the abdominals are also moving with it. So you can have your hands near the lower part of your rib cage so you can feel the abdominals too. Can you feel the difference when you breathe like that? Yep. How did that feel in your body? So come off the chair for a moment so I can see your faces. Match everybody's face at the same time rather than having to scroll through you occasionally. How did that feel, the difference between them? Rachel?
Yeah, much easier. The second one just felt kind of freer and easier.
Yep.
Yeah.
Good.
Yeah, Abby, when we did, hi, it's Wendy.
Hi.
When we did that first one, and you were saying who felt it in the belly, who felt it in the chest, I kind of felt it first in my belly, so that's why I said, yeah, I think I'm a belly breather. But actually, when you got me to do that without the ribs, that wasn't what I felt at all, because that was really hard to kind of keep the ribs not moving. But is it right then? Because I think when I was doing it without the consciousness, I felt it low in my tummy, but it did rise up and all the way around. So is it wrong to feel it first lower than your ribs? Should it feel in your ribs? Because I felt it in my belly, but ribs.
So you should feel it in your ribs first. So the reason for this is your lungs are housed in your rib cage. So as we inhale, the first thing that should be expanding is the area where the lungs are, so the lungs can inflate fully. So if we think ribs, the ribs should start to move first, and as they move, they are the primary stimulus for the transverse to move and for the obliques to move. So as you start to widen your rib cage, your obliques and transverse will move almost at exactly the same time, but it is the rib cage that is the stimulus for the movement for the body. And the reason for that is because, you know, it's the lungs that we're filling. So we want to create more space for the lungs in our body when we breathe. So that's why. But yes, you should feel it. And you know, I go into much more detail in this when we do the breath bit, where we get into more practical. We'll go into much more detail about being able to feel it all the way through the whole torso area. But to have that initial stimulus with the rib cage. So many, yeah, sorry, Wendy.
I was going to say, some courses, or when you learn some techniques, I think it can be misleading because some people do direct you. And I think I've practiced that over time, is breathe into your belly, breathe into your belly. Apart from when you're doing your Pilates breathing, it's when you're doing your relaxation and meditation. I've had a lot of instructors and teachers saying, right, just relax and breathe into your belly. And I think that's obviously quite misleading then.
Yeah, so I did, because I've had so much of this, that I went and looked at where this comes from. So the yoga breathing, the breathing into your belly, if you actually look at the description of it, the proper description of it, it says 3 fingers above your belly button and 3 fingers in. And if you think about where that is, and then visualize where that is. So if you've got your 3 fingers above your belly button, now I'd like you to widen your rib cage to do your breath, and think about where your diaphragm goes when you widen your rib cage. If you widen your rib cage all the way around, your diaphragm stretches out and descends to that point. So true belly breathing, breathing into the center of you, we get when we widen our rib cage. Deborah, you had something to say. Oh, you're muted.
A recent client, when I asked him to breathe, he very much breathed into his belly as a natural breath, and he said that's because he's doing drama classes, and he's been told that's the way to breathe.
Yeah, a lot of singers get told that's the way to breathe too, is to breathe into their abdominals to get the breath. But actually, to get the, I know I went to drama school, so I also got taught that method as well initially. So But actually, to get the full breath and to get the full expansion of the lungs, we need to widen our rib cage. And to control the out breath, we need to be able to control the diaphragm slowly closing. And if you're not activating the diaphragm in that way, you're going to find it really difficult to do. Also, if we bypass the rib cage and create, what's happening is all the pressure is then pushing straight out into the abdominal area. And if you've got a weakness in the linea alba, or you've got a weakness in your the hernias, the groin hernias, which names escaped me again, or you've got lower back stuff going on, the pressure is going to push to where that weakness is, or a weak pelvic floor. So what's going to happen is the pressure will find the easiest exit route, so to speak. So yeah, if he's doing drama, he should definitely be widening his rib cage, and you can explain why now. Yeah. I spent 4 years at drama school.
I had my observation, I think it ties in with you. So when I was doing the widening sort of like into the rib cage, everything felt kind of like more relaxed down in the pelvic floor area.
Yes. Mm-hmm.
And I was belly breathing. I had an uncontrollable sort of movement in the pelvic floor. Just couldn't stop. Is that?
Yes.
Perfect.
Yeah, perfect.
There it was, just sort of like a little knee-jerk reaction.
Yeah, perfect. So what's happening is when we do the belly breathing, when we don't move the rib cage, which I mean, and so many women come to me and men with totally fixed rib cages that cannot move at all. What happens is that the pressure pushes into the weak area. So for you, that was the pelvic floor. That's where you felt it. And we're going to do a cough test and things in a bit when we get onto the floor and do the practical section, where you'll feel where that might be happening and where the weakness might be for you. But yeah, it will find its weak points. Nikki.
Yeah, you just mentioned coughing. I'm on week 3 of this horrendous cough and chesty cough that's been going around. And when we were doing that breathing, I actually, again, you know, the one when we did the belly first, I thought I actually need to go to the loo.
Yeah.
I've noticed from all the coughing that I've been doing, not only did my rib cage hurt, but I've had to start doing pelvic floor exercise again. It's really weakened it. So I guess it's all that pressure.
It's the pressure, eh? The coughing, defecating and throwing up are the 3 biggest pressure increasers for the body. For you, if you're coughing just now, Nikki, if you need to cough, what a good thing to do, and this is for clients who have coughs too, is just lean forward a little bit. So when you lean forward a little bit, it dissipates the pressure. If you think instead of being upright, where the pressure is going to come straight down, you know, if you think about it going through the diaphragms, if we lean forward a little bit, either standing or sitting, it's almost like the pressure is running out on itself. So you decrease the pressure by inclining your body, which is a great thing to do. It's much easier.
If you see me leaning over, you know.
It's better than crossing your legs and kind of increasing tension, you know, which is going to actually make things worse. So yeah, yes, Rachel.
But both diaphragms, when you breathe in, are contracting down, aren't they? The pelvic floor and the pelvic diaphragm and the breathing diaphragm.
Yes.
I mean, I know for me, and it was really interesting what you said about horse riders, and yeah, I used to be a professional show jumper, so I'm very so I find it really, I can feel the ribs moving and I can feel everything widening, but I can never feel that kind of release.
Yep.
But I don't know how that feels for other clients. And I'm thinking, teaching wise, I've always encouraged people to concentrate on that pelvic diaphragm release as they breathe in, which maybe is encouraging them to go too low into the belly.
It could be. So basically, to start with, when I start with teaching people, I don't talk about the pelvic floor at all. We just focus on the ribcage expansion. If the ribcage is expanding, then the diaphragm, what happens is as the ribcage expands, the central tendon of the diaphragm draws down and contracts, and the muscles stretch out. The pelvic floor does exactly the same thing. As long as we are getting that opening of the ribcage initially, it follows suit. So what happens with the pelvic floor? It stretches out, it extends, and it descends a little. But I try not to talk about the descending too much, because although we are gently loading it with each breath, I like people to think about it more like it's a release or an expansion. Because essentially, as we open our rib cage, our sit bones widen a little, and they don't widen massively. And when we get to the sitting pose, I'll explain why I never give that as a cue anymore. But they do widen a little. Our coccyx curls out from underneath our pelvic floor a little, and this creates more space in the paraspinals for the widening of the rib cage on the inhale. So we've got this cool connection that goes on, and the pubic symphysis gives a little. So we have this widening of the bones in the pelvic floor that is reciprocated. It's the same movement that we have when we are widening our rib cage. So we've got a corresponding movement pattern happening in the pelvis. So as our sit bones widen a little during the inhale, our ASIS bones draw in because they're the other end of that bone. So the sit bones, the ischial tuberosities at the bottom, are the other side of this part of the bone here, and there's a little kind of twist in the bone, so that as we inhale and our sit bones widen, our ASIS bones draw in a little, giving us more space in the abdominals for us to do that inhale and expansion that happens because we're widening our rib cage. So as long as we're widening our rib cage, we're getting this expansion in the diaphragm. We are also going to be getting that movement with the sit bones and the movement of the coccyx. At the same time as all of that is happening, where was my brain going? There was another bit I had to say here. At the same time as the psoas muscle comes from T10, T12 here, comes down your spine. It's got connections all the way down your spine. And it comes into your pelvis and it mixes with the iliacus muscle and becomes part of the same muscle group in your pelvis. So that's at the back here. And then it crosses through your pelvis to your femur at the front and connects to the femur at the front. Every time we inhale and expand our rib cage, our diaphragm stretches out and descends a little. The psoas also descends, releasing that kind of whole area of our pelvic floor. So we have a release in our pelvic floor, which allows the pelvic floor to also absorb the pressure. So this whole torso area, as we inhale, becomes an opening almost for that pressure. On top of that, we have a cool fascia connection that goes from it actually comes from our sacrum through our pelvic floor to our bladder, our pubic symphysis and our bladder, and then comes into our up towards our belly button. And it used to be the end part of it used to be the tube we excreted urine into our mum until we were 12 weeks in utero. And that then also comes into the fascial line that comes all the way up through the anterior chain to the falciform ligament of the liver, and then continues up through the diaphragm towards the heart. So when we do an inhale and widen our rib cage and open our diaphragm in all the directions it can open in, it allows that line to release. So the whole front part of the pelvic area and the frontal line releases. And again, allows that space for the expansion of the rib cage. And then as we exhale and the rib cage closes, it draws this back up again. So we have a really cool movement pattern that expands this way, but also lowers this way. And then as this comes in, this lifts up. So it's the breath should be a whole body movement. That was a lot of anatomy all at once. Yeah. So there's a lot going on when we breathe, but if we breathe using our rib cage, widening our rib cage towards the sides and behind, and get this 360 movement pattern with a little bit of movement in the sternum here, which we'll talk about when we do it, then what we're doing is we're getting that activation anyway, without us having to think about it at all, which is the beauty of this. We can teach the clients the apnea and the rib cage opening, and their pelvic floor should start to follow suit. So as we inhale, we widen. As we exhale, everything draws back to a resting place. And this is the really important thing. Things come back to a resting tone, a resting place. We're not bringing our pelvic floor back to tension. We're not bringing our diaphragm back to tension. We're bringing it back to its resting place. So we're not forcing the rib cage closed, because that would create loads of tension in the abdominals and everything. We want to bring everything back to a resting point. And if we have great resting tone throughout the muscles and the fascia in our body, then they're much more able to adapt to movement patterns that we're doing, coughing, jumping, all these things, because they're ready to go. They're not held in tension. And then if you've got a really tight pelvic floor and you cough, you're going to pee yourself. If you've got a really tight pelvic floor and you jump on a trampoline, you're going to pee yourself. It's going to give way because it's just too much load on the muscles. So we want great resting tone, and we want to have our body hanging out in resting tone so that it can then activate when we need it to activate. And that's kind of where we all go to. That's what Hypopressives is all about, is creating that really, really great resting tone throughout the whole of our body. Okay, so we'll do the rest of the slides and then we'll have a break. So I'll go back to share screen. We've covered quite a lot of the slides already, which is the best way to cover them, is like this instead of slides. So breathing patterns. This is a lot more detail here in your handout about all the different breathing patterns. So as well, and hopefully you've got this handout, because Lee sent out the wrong one to last group, so I'm hoping you've got the one that's got the white rather than the black. And then we've got belly breathing, a little bit more information into that, but we've talked about it now as well, so we've done that. And we are doing in Hypopressives the 360 lateral costal breathing, and we have talked about this as well. So so in 360, just to nail it down, in 360-degree breathing, the diaphragm takes center stage, contracting downward to generate intra-abdominal pressure, driving expansion in the abdominal muscles and the pelvic floor. This regulation of intra-abdominal pressure plays a preventative role against hernias, prolapse, diastasis recti, and back pain. So there is an increase in intra-abdominal pressure, but it's a managed increase. It's not something where we're just pressing into one point. We're increasing the pressure all the way around. And then when we come to do our apnea breath, we're going to decrease that pressure. So achieving correct diaphragmatic expansion in 360-degree contributes to the relaxation of the psoas, the quadratus lumborum, which can never be overlooked, and I always kind of slide by it, which I shouldn't, and paraspinals, while simultaneously activating the core and the pelvic floor muscles. This balance is crucial, especially considering that many individuals often experience tightness in the psoas, quadratus lumborum, back muscles, and couple this with a weakness in the core and the pelvic floor. So what we're doing is retraining muscles back to the pattern they ought to be in, because people's postural choices and life choices and trauma have taken them into a position where they maybe have scar tissue that's impeding this, or patterns of movement that are impeding great movement. So we're going to do a quick overview of fascia. There's an overview because I do a lot more detail in the next one. So fascia is not just a thin layer of connective tissue. It is that as well, but it's many other things. It's got many other hats that envelops and supports various structures in the body, including organs, blood vessels, bones, nerve fibers, and muscles. And now we're also hearing Robert Shearer also talks about how he believes that bone is also a part of our fascia system. This tissue serves not only as a structural framework, but also possesses nerves. So our fascia is really, really sensitive as well. So it's to be aware of just that the nerve endings and the pain receptors in our body. They did a study just before COVID. I say just before COVID now. It was 2019. There was a study about where the pain receptors are in the body, and they discovered that the pain receptors were mainly in the fascia surrounding the muscles. So that's why people can have a back injury, and their back injury is healed compared. Their physiotherapist says you're healed. You shouldn't be feeling any pain anymore, but they are still feeling pain, and it's because the fascia hasn't been released. So the fascia is still dry, the fascia is still tight, and it's that tightness in the fascia that is squeezing or sending messages through the pain receptors that there is still imbalance. So this is, again, quite a new area. It makes it highly sensitive, almost to the comparable sensitivity to the skin. When under stress, fascia has a tendency to tighten up or dry. Okay. What we're doing is we are doing active stretching when we're doing hypopressives, especially in this foundational layer. So fascia is the complex connective tissue. It plays a crucial role in the body's functions with its diverse components. Maintaining the suppleness of the fascia requires varied movements. We have to have multiple movements. And while static stretching addresses some aspects, it falls short of addressing the entirety. Fascial stretching involving multi-directional stretches untangles the intricate web of connective tissue, promoting overall balance. So, when disrupted or misused, fascia may thicken, harden, or become blocked, like a dam. If you think about a dam on a river, emphasizing the importance of proper movement. If we get stuck in one pattern, then it all gets tight and dry. And in order to mobilize it again and get the moisture flowing through it, we need to find lots of different ways to move it, just as we poke a dam in different positions to get the water to flow back through it. Unlike muscles, fascia doesn't respond well to force. Instead, gentle, sustained stretching is key for inducing change. Engaging multidimensional movements and stretching fascial tissues can effectively alleviate tension, stiffness, and pain throughout the body. What we're going to be doing in hypopressives is we're going to be doing what's called a visceral traction. So we're going to use the active stretching of the fascia and muscle chains combined with the tensioning and compression of the torso during the breath phase to create a visceral traction, which when combined with the apnea breath is increased, creating a vacuum breath. And we're going to talk about this in much more detail when we do it practically. There is no active sucking up or pulling up. There is no Kegel type involuntary movement happening. If we were to do a Kegel movement and tighten the pelvic floor, as we're trying to get the fascia and the diaphragm and the visceral traction to draw it up, it would mean the pelvic floor would find it much more difficult to move. If we've got the pelvic floor at a nice resting position, and then we create the visceral traction we're going to create within the parietal fascia, we draw the organs up. So we're going to be working with the fascia that comes all the way around the abdominals, all the way around the top of the pelvic organs, and all the way up round the torso to the diaphragm. The engagement comes from slow, mindful, active lengthening and a slow opening of the ribs that is held for as long as comfortable for the person performing the apnea. In hypopressives, we have a series of postures we move through in a flow. However, the principles can be applied to other modalities, but keep it as a flow. Try not to keep it too, just holding one thing for ages and ages, as long as the key principles are adhered to, which we'll talk about. Okay, some cool videos before we break for our wee pee break and things. So sit up on the pelvic floor. So we are going to look at some full frontals of vulvas. So just be prepared for that and make sure that there's nobody in the room that doesn't want to perhaps look at them. Yeah, just checking. So just prepare you, because I get sent pictures of vulvas and sometimes my kids are there when I open them and I don't realize I'm opening what I'm opening. So this is a sit up performed by somebody that's got very little core activation. And we can see as she sits up how her pelvic organs are being pushed out. So this is an increase in pressure, which happens when this probably happens when she coughs. It'll probably happen when she sneezes. She's got this increase in pressure in the pelvic floor. So this is the pelvic floor during an apnea, and this is with a bladder prolapse.
Abierta, haz un hipopresivo. Ponte en posición, haz el hipopresivo. Eso respiro, eso es. Tira, fuerte, más. Aguanta todo lo que puedas. Cuando no puedas más, coges aire y relajas. Pasar. Muy bien. Ahora quiero que me hagas un abdominal normal o algún ejercicio de pilates. Así que puedes hacer tumbada.
Okay, so to start with, when the pelvic organs start to be drawn up during the apnea breath, when you finish the apnea breath and inhale again, they come back down. But as you increase the resting tone in the ligaments and the muscles and the fascia, the organ gets held up further and further up. It is a gradual process. Ligaments take a really long time to remodel. Fascia takes a long time to again find its resting tone, and we know how long muscles take. If you're looking to increase muscle strength in a gym and see decided change, it's 3 to 6 months, for an actual active, change in our body that's visible. So it does take time. And so, I mean, mine felt like that when I first did it. My bladder prolapse felt, because that's exactly what it looked like. And that could have been me, but isn't. So you rest assured. So it felt, you can feel that pulling up and then the coming back down. And slowly over time, it comes down less and less and less until it doesn't come down anymore at all. We look in the hypopressives, we err on the side of caution with saying how amazingly cured people will be or treated they'll be, by saying that their prolapse could change by a grade. So if they're a grade 3, a grade 2, but they'll become, their symptoms will go. A grade 2, a grade 1, a grade 1, a grade 0. However, mine went from that, which was a grade 3, all the way to a 0. And there is, that can happen too. But I like to make sure I manage people's expectations and don't say this is going to absolutely utterly save you, because there are other things that come into play with pelvic floor dysfunction: stress, tiredness, connective tissues. I mean, I am hypermobile, but not to the degree that quite a lot of my clients are. The other ones are trauma, scar tissue. Trauma, especially trauma stuck in the tissues, can really affect you. I had a massive jump in my healing journey when I addressed the trauma of my first birth. So this is why this is a tool to be used in combination with other things, because the most dramatic healing comes when people address what else is going on in their lives with stress and trauma too. Okay, so female pelvic organs and the floor. This is a pelvic floor, and these are the pelvic organs. And the pelvic floor muscles come across the bottom of the actual pelvis itself. Our pelvic organs are not held in a floor; they're held more like a hammock, suspended by ligaments and fascia. The fascia wraps around them in a really beautiful way, helping connect everything together. If somebody has a hysterectomy and their uterus is removed, then we have a break in the connection between all three of these organs. And so that can quite often will happen is they'll have, after they've had a hysterectomy, is they'll have a bladder prolapse or a rectocele. So I make sure that if people are going for a hysterectomy and have chosen to do that for whatever reason they have chosen to do it, that they make sure that their surgeon gives them a stitch on either side just initially to hold things up in place, so we can work on creating better resting tone throughout the body without the uterus there, initially without anything falling or moving in towards the vaginal canal. So this is a picture for you to see this, what it looks like, and also to see how supported the bladder is by the pubic bone at the front. The male and female, so hypopressives are not solely for women. Hypopressives are also beneficial to men who have connective tissue disorders, bladder and anal incontinence. For men, bladder and erectile dysfunction can be compromised due to a prostate removal, which for many is an elective surgery to avoid cancer. Men also suffer from pudendal neuralgia, which is a burn. It can be a stabbing pain in the pelvis. It can be burning in the pelvis. It can be just a feeling of being disquieted in your body. And this could be especially from activities like cycling. So if they haven't got the right cycling seat on and they go cycling all the time, they can have real issues with this, women and men. This is to show you how similar the pelvic floors are in men and women. There's not a great deal of difference. There's more space for ours to go wrong, but they have the same. So I've had a lot of men who've had prostate removal. And they've actually all been from the same army regiment, most of them, and they've chosen to have prostate removal, and they were not informed fully of the fact that they'd have erectile dysfunction afterwards. They were told they might have incontinence, but the erectile dysfunction thing wasn't really discussed, and they found hypopressives was amazing for increasing their erectile function, which it was life-changing for all of them actually, because they thought that was over at 50. So they're back firing on all cylinders, I guess. So I've had lots of, to be honest, the men with erectile dysfunction work so much harder at the homework than my women do, because it's such a real thing about their masculinity. So they're really consistent in their practice. And they find time in their day. And to be honest, they're generally, even when they're dads, they're not juggling childcare and things as much as my women are. So they tend to have more time to spend on themselves. Again, we've talked already in my description about how it's not the sole operator. We are wrong to treat the pelvic floor as a separate entity, because it most certainly isn't. Its connections to the rest of the body are multifaceted and numerous. The pelvic floor has many hats in its role as part of the team: breath, sex, stability, support for internal organs. It's a sphincters, and it's a sump pump, circulating lymphatic fluid. And these pictures are here to show you just how connected that psoas is to the pelvic floor, how connected the transverse is, how close it is, the multifidus. These all work together. And doing just pelvic floor exercises on their own, like squeezies, is not going to give you the functionality in your pelvic floor that you need, because all of this ties in. It's quite amazing, actually, how connected it is. This is to give you a bit of an idea about different prolapses. There is the one that's not on here is a rectal prolapse, where the bowel comes straight out through the rectum. But we do have most of them here. There are others like vaginal vault prolapse as well, but these are the kind of standard ones you see. Although enteroceal is quite rare. Enteroceal tends to happen more with my women who have had a hysterectomy. So that's when the small bowel comes and pushes down into the vaginal wall or into the perineum. So cystocele is a bladder prolapse. Rectocele is a pushing in of the rectum towards the vaginal canal, so it comes out through the vagina. And the uterine prolapse is where the uterus comes straight down through the vagina. And quite often women will have a combination of these. It's very rare they'll have one. They might not know about the other one till they fix one. Rectocele is the hardest because it doesn't have that direct connection through that anterior chain of the fascia. It takes the longest to remedy, because we need to really work on the parietal fascia and the posterior chain. It's harder to get into. So the diaphragm, a little bit about the diaphragm. It has connections throughout the body and creates activations in the vagal nerve, psoas muscle, adrenal glands, an anterior fascial chain that runs through the falciform ligament of the liver down to the bladder. And it moves, as it moves, it massages the heart, the upper abdominals, and it helps to mobilize the lymphatic system. And we've got a great wee video of its movement pattern. And as it moves, I never cue the opening of the ribcage to the front, because we don't need to, because our body really, really does do it very, very naturally. It's going to show us again. The role of the diaphragm in our body, it's for breath, stabilizing the trunk, places pressure on the esophagus to prevent acid reflux. So my women with hiatal hernias, we can talk about that in a little bit of detail when we go through it, as things that you can use. It starts to really help with hiatal hernias, creating a much more functional diaphragm. It helps with phonation, prevents herniation of the abdominal organs into the chest cavity, and the central tendon contracts as we inhale and releases as we exhale. But here again, this picture's here so you can just see how many connections there are here. What goes through. So the central tendon is the grey matter here at the front, or the white matter. But we can see the connection into the lumbar spine, the quadratus lumborum, the psoas. Everything is so interconnected. We've also got this is just for observation, how important it is as well for the vena cava, for our blood supply through our body, and how interconnected, how the vena cava even connects us with the pelvis. So that activation through the diaphragm moving, that pumping of the blood through, and this is how we get more blood circulation into the pelvis if we're using the diaphragm and really using it to stretching it and then compressing it again back in, or stretching it and then releasing it is a better one. And how much more circulation we'll get if we're using it effectively. We are going to do a lot of dorsiflexion, and people always ask why we're dorsiflexing. So there's been loads of studies done on how the abdominal vacuum, which is the ADIM, along with contraction, along with the co-contraction of the feet, increases. It really helps increase the transverse muscle. So we activate the transverse muscle massively if we dorsiflex. Just even if we dorsiflex a little, we actually can feel the activation into our abdominals and into our transverse. So what we're doing is adding a little bit of extra activation. Also, the dorsiflexion of our feet activates our big toe. Our big toe has a fascia connection that goes all the way to the back of our tongue. So we're getting that extra activation through the fascia chains in the body. So it really, and this study was done on lower back pain and how effective dorsiflexing with the abdominal vacuum is to increase mobility and tone in the lower back and remove pain. There have been more studies done on low back pain than there have been on pelvic floors for hypopressives. So there's a little bit more information for you to read over later about the dorsiflexion as well and how important it is. A lack of range, this is important if you're looking at women's posture and men's posture. If they've got knee valgus, it quite often can mean that they don't have the flexibility in the ankles, and it would lead to poor pelvic and hip mobility as well. So increased range of movement is imperative for our pelvic floor. The tongue has a complete connection that goes all the way through our pelvic floor, all the way to our toes as well. And our eyes are, we'll talk about our eyes when we get to eyes. I'm going to come back to the eyes. And feet. There are 250 to 300,000 nerve endings in your feet. In each foot, your sciatic nerve ends up here, as do branches of your femoral nerve. These nerve endings all share the same nerve root with your pelvic floor, S1, S2, so in the sacral complex. And so if we innervate our feet and have functional feet, that's going to relate to a more functional pelvic floor. And there's actually a surgeon in the UK that looks at women's feet before he looks at their pelvic floors, and he only looks at their pelvis and their pelvic floor and their pelvic organs to reaffirm what he's worked out from their feet. So if you ever want surgery, you want him, I think. Contraindications is the last thing before we have a little break. So pregnancy is a contraindication. We don't want to squish the baby when we do the apnea breath. But the breath work, the 360 lateral breathing. Victoria, you're looking through this like you've got the wrong slides. Has Lee sent you guys the wrong slides as well?
Yeah, we don't have this.
Yeah, we don't have this. We have we have that as the next page.
Yeah. So I redid them because lots of people wanted it differently, and Lee wanted it with less black in it for printing. So I will send him a message and enclose this and get him to send this out in the future. What I'll do for you guys though is I'll send you this one after the session today, so you have this one. So you have all the contraindications and everything else in there as well. So I adapted it after the first session, so I will send it out to you. And I'll send a reminder to Lee. I know he's been really busy, so that'll be why. He's probably just got one earmarked in his box. He's just printed off. So I will send that. So this again, the lateral breathing during pregnancy is really important. The psoas, and lots of literature now, the psoas in pregnancy should, if it's flexible and mobile enough, act like a runway for the baby to come out. If your psoas is supple and flexible enough, the baby should sit much further back in your body, and you'll have less likelihood of having a diastasis afterwards. Also, you should have a much easier birth. What a lot of women start doing is they really, because they don't have that mobility in the thoracic area, is they start really having to flare their ribcage to the front to get any breath, which creates a really lordotic spine, a really tight psoas, and a belly that's really far out in front. And then when it comes to giving birth, the psoas is really, really tight and unable to give that direction for the baby. So in lots of holistic pregnancy, they really work on the flexibility of the psoas to improve the functionality of it for the birth. So continuing doing hypopressives without the apnea during pregnancy is it's a great way to keep that flexibility in your psoas. So a lot of my women who've come to me after their first baby then stay through their subsequent pregnancies and then bring the apnea back in again afterwards. So I've had multiple pregnant women working through my routines now, and I'll talk about the difference with the breath work for them. So after the first trimester, the one thing is that they should not be in a prolonged lying supine due to the potential constriction on the vena cava. So you can have them propped up for the supine poses, the same as you would if you were doing pregnancy Pilates. So it's the same. Other contraindications, EDS vascular. Hypertension, so it's that's not under medical control. If they've got it, if they're being medicalized for it and they've got it under control, they can do the apnea breath. And what I do get them to do is go back and check regularly with their doctors, because usually they need to lower the medication as they start to breathe well. Any operation on your heart or any thoracic organ, except the gallbladder is totally fine. So again, this is about the increase in pressure. They can still do the breath work and still do the poses, just not the apnea. And COPD is the same. You can absolutely, utterly do the breath work. It's great for every part of your body, but just not the apnea, because they're already starved of the right amount of oxygen. So residual oxygen is low in COPD. And during a flare of IBS or Crohn's, your abdominals are already going at you, and you don't want to squeeze them anymore and irritate them. So again, my clients who have IBS and Crohn's have had fewer flares after they start practicing hypopressives. So they have to take the apnea out less and less and less as they go through. Okay, there's so many different things can go on with people's bodies. If we just think we're increasing pressure in the thoracic area, and so anybody that might affect, we don't want them to be doing the apnea breath.
Can I just ask a question about the Ehlers-Danlos syndrome? I did my hypermobility training, and I obviously really need to relook at it. I don't remember the difference, or I don't remember it being there about vascular EDS. It probably is there and I just can't remember it. But how does a client know whether they've got regular EDS or vascular EDS? What is the...
If they have vascular EDS, they'll have had other complications like POTS, so tachycardia and things like that, which will come along with it. It very rarely vascular EDS comes without other complications. So all my clients that have come to me with EDS, when I've asked them if they've got vascular or not, they've very clearly known whether it's hypermobility or apart from that one who was my trainer, who was like this. And I do look at people when they come in to make sure that, because some people are undiagnosed. So if you find a client who's really hypermobile or looks like they've got really stretchy skin, then I get them to get checked out first.
And
I have it on my intake form, Rachel, to make sure that people think about it before they come. To be honest, the risk is low. The risk is super low because the increase in pressure is not massive, but it is a protection thing for everybody. So the risk is really low, but it is there. So it's just to be aware of. So
I know I have a couple of clients with EDS who are really hypermobile, but I don't. They would know if they had vascular. They would definitely know if they had vascular. I've not had a single client who's come to me who's not known that they've got vascular EDS. It comes with so many other complications generally as well, and they've generally had issues with leaking aortas or things like that already, because what happens is the veins and the arteries become really hypermobile as well. And that's what so if we're increasing pressure around the heart area and we've got ligaments and not ligaments, but veins and arteries that are much more stretchy, then there's a potential for them pulling apart or things happening to them, which we don't want to happen. So it's there as an advice. To be honest, when I first learned and when I first did this, it wasn't even in there as a contraindication. I brought it in at the IHC because I've worked with so many people now with EDS, and I'm really aware of the fact that the vascular one is there, but they've all come with other things, and it's generally been tachycardia, so they know they've got a heart issue already, so that should always be flagged in your forms. Thank you.
That's okay. I've got a friend who's a Pilates teacher, and he's very, very, very queued up on EDS, so I always ask him for advice as well. So it's good to just make sure we're sharing information with each other, as well. Okay, all the other information that's on the one that you don't have that I'm going to send to you is all now for you to look back on. So there's information about the apnea, there's information about how to troubleshoot it. That's my son, he does a better dramatic apnea than me. We're going to do the visualizations together, but they're there for you to go look back on. There's space for notes, and then I've done a breakdown of all the poses we're going to be looking at. and I'll send that all to you. So don't worry about that. It'll all come out to you. I'll do it straight after today's session, so you've got it to look back on. We're going to have a short break. We're going to have like a 15-minute break to pee, drink some water, and get your mats ready. And then we're going to come back and we are going to learn the breath work and the apnea and the first tests and assessments I do with people. And then we're going to break at 12:30 for lunch, and to give you time to think about all of that and come back with loads of questions. And then we're going to mobilise the apnea after lunch, after a little refresher. So, okay, that's the plan. So I will see you back here at 12, I think would be good. Yeah, well, that's not quite 15 minutes. Let's come back at 5 past, and that gives us 25 minutes to get really nitty gritty with some practical. Okay, guys, I will see you shortly. Yeah? Okay, I'll pause this. Oh, change camera. Go lie down. Lie down. If you want to come out of the house, you have to lie down. If you want to be outside, don't be a pain. Okay, I'll just let everybody start to come back. Does anybody have any questions as people come back before we... Cool.
Hi, Abby. I've got
Yes.
a question about Restore Your Core, Lauren O'Hayan. I've started
Yes.
looking at some of her stuff. How does that, do you know how it kind of tallies with what you do?
Yeah, so the breath work that Lauren uses is exactly the same. The 360 lateral breathing is exactly the same as the breath that we use here. And because it is a functional breath, and she uses exactly the same. It's Lauren ties her stuff in more with, I mean, she's nuts about feet like I am too. And so that's all of that's really, really similar. It's just that hers is more from a yoga point of view. So she does everything much more from a yoga point of view.
Yeah.
But it's the same breath work without the apnea, with kind of more like yoga postures that she uses.
Okay.
But there's so much crossover between what I teach and what Lauren teaches. It's always quite astounding. I did one of her courses recently, for fun, just to see if we were still the same, and we are really, really similar in what we teach. It's just that what we teach with the active stretching isn't what she teaches. She teaches it more through a kind of a yoga perspective. Yeah. She's also done a course with Trista in Canada as well. So she's also done Hypopressives as well. So there's tie-ins to what she does too, as well. But yeah.
I loved her course she tied up with Gait Happens.
Oh my God, I did that course. It was brilliant. Yeah, because Gait Happens. I discovered Gait Happens during lockdown, and I couldn't believe there was somebody quite so nerdy about feet and pelvic floors as she was. So yeah, and when Lauren did the thing with her, I was like, oh my God, I'm gonna buy that. So I'm like, I've not finished it yet because I've got so much on, but I'm halfway through. Did you enjoy it?
Yeah, loved it. It was just the very quick sort of introduction to it that I
Oh right,
yeah, like you, I've not got time to do the whole thing, but
I bought the whole thing, so you get it for a lifetime. So I know it's out there waiting for me. So I kind of dip in when I've got time, but
yeah.
It's brilliant. Yeah.
Oh, great,
So,
thank you.
But there's so many parallels. It's the same with oh God, it used to be Restore Your Core. It is Restore Your Core, as well, which is the Jenny Burrell stuff, and she does again really similar breath work. It's Lauren O'Hayan, Kerry. Lauren O'Hayan. She does her breath. Jenny Burrell does really similar breath work, the lateral breathing again, because it is the way that we connect to the pelvic floor. But she ties it in with weight training and stuff as well. So again, it's a really, really similar. There's so many crossovers. Victoria.
Yeah, what was the gate thing you just mentioned?
It happens. They're in Colorado, but they have an amazing online program. So I bought it during lockdown and did so much of their foot stuff, and it's just amazing. And the feet really are the windows to the pelvic floor. So it's just, if the more you know about feet and foot position and how it affects the hip and things, and the back and everything. The feet are I start from the feet up when I teach hypopressives generally, when it comes to standing anyway. Yeah, there's so much crossover with what Jenny Burrell teaches as well. And even the other one that's available in the NHS is the Mutu system, which I did, because I did it and I got thoroughly bored halfway through, but I finished it. And again, the breath work is really similar. It's just that they tie it in with really functional movement patterns. So it's just a different way of looking at it. But it was just too repetitive for me. There wasn't enough interest. If I'd done that postnatally, I'd have probably died of boredom. But yeah, but there are some really good things in it that I have nicked that I use in general classes, because I kind of, I'm a bit of a magpie with stuff that really works for people. I bring it into my practice.
Okay.
Yeah.
What was that one on the NHS that you said?
It's called the Mutu system, MUTU, the Mutu system. They do our 360 breath as well. She's been a bit of a magpie too, because there's bits from Feldenkrais in there. There's bits from the Franklin method in there. There's like embodiment from the Franklin method. She's definitely taken that from there. I see bits that I know I've collected like a magpie that are in there too. She's made it really repetitive because people need to repeat things over and over again for it to become stuck, but it's almost a little bit too repetitive. But it's worth looking at, Yeah. It's pretty cheap to buy. But it's the one that's recommended by forward-thinking people in the NHS.
Aren't we all magpies?
Yeah, I think we all are. Yeah, I think we all are.
Magpie.
Yeah, it's you do grasp bits that work really well with the program that you're teaching or the method that you're teaching and add it in, so things just grow over time as our experience grows, I think.
I did
Yes.
foot workshop with Madeline Black yesterday.
Oh, wow.
That was really interesting. Yeah, and then there's another one in a couple of weeks on the pelvis and the link between the feet and the pelvis.
It's huge. The link between the feet and the pelvis is huge, and the orientation of the feet and the pelvis is huge. The nerves, the muscular connections, especially the muscular connections that come up the legs and the adductors. There's a huge connection with the adductors and the pelvic floor, which we're going to explore in our first pose and some of our poses too. So, shall we, I don't know, am I on time or am I I'm always early, I'm just like, right, let's get going. Yeah, I'm on time, let's get going. So, let's get going. So, the first thing we're going to do is a series of tests, and we're going to do, I'm going to show, I'll talk through them with you, so that you've got them on video as well, rather than me just talking through and watching you, which I've done sometimes. So, what we're going to do is we're going to lie on our backs with our knees bent and our feet flat on the floor. And when I first meet clients, this is where I get them to be, because it's easy for me to determine what's going on with their bodies online as well as in person. So I don't get them to change anything. I don't want you to try and find neutral, do anything at all like that. All I'd like you to do is land and be on the floor. I'm going to get you to do a series of things now that we're on the floor. So the first are a couple of assessments, and I'll send the assessment sheet out to you as well. I tend not to work from the sheet anymore. I just use these core assessments. There are hundreds of assessments you can do of people's posture, but I want to get to the nitty-gritty of where the weakness is in my clients' cores and bodies. So the first one I do is I get them to breathe, and we've done that already. But what I would do first of all is get them to breathe, and I would observe how they're breathing and get them to think about how they're breathing too. So what I'd like you to do is just as you land on the floor, I'd like you just to be aware of how you're breathing, and I'd like you to try and take it to more of a 360 breath. But if I was looking at a client, I'd be looking for the belly coming up first, I'd be looking for the shoulders to be raised and the chest to be thrusting forward, all of these things we talked about with the different breathing patterns earlier. The next assessment that I do for people is I try to find out how compliant or how much activation they have in their big deep transverse muscle when we increase the pressure there. So what I'm going to get you to do is cough, and as you cough I'd like you to feel what happens to your abdominal area, and I'm going to give you the grading afterwards so you don't cheat. So just cough and feel what happens to your abdominals. You can put your hand on your abdominals to feel it. what happens? Do you feel that when you cough that your abdominals come up and take ages to come back down? Do you feel that when you cough, your abdominals come up quickly and then come back down quickly? Do you feel that when you cough, your abdominals stay where they are? Or do you, when you cough, feel that your abdominals go in as if they're absorbing the pressure? So now you've had a little bit of an overview again. Try it again and see what you think yours do. So if they come up and stay up for ages, that would be graded as a 3. So it means that our deep transverse organ is, our deep transverse muscle is not working to help sustain or control the pressure of the cough. If we cough and it comes up and goes straight back down again, it means our transverse is kicking in a little and is able to try and maintain the pressure of the cough. If we cough and it stays where it is, it's pretty good. So that would be a 1. The other one's a 2. And if as we cough, our transverse feels like it's drawing in the way naturally, then that's a 0. And when my kids cough, that's what happens with theirs. When I cough now, it stays where it is. But when I first did this exercise, it came up, moved about for ages, took a really long time to come down because I had such a massive diastasis. And generally when that happens with a client, I tend to look for the diastasis next. So I would do a diastasis check next, because it's shown that the transverse is not doing what I'm expecting it to do when they cough. Yes, please.
When I cough, I feel like the top abdominals go in, but my lower belly comes out.
So you've got 2 parts of your abdominals, really, with the muscles, with the transverse muscle. And that's why we always check a diastasis from above the belly button and below the belly button. So what's that showing me is that you've got compliance in the upper area, or you might be rib gripping, so there might be one of the 2 happening. And then the bottom abdominal area, you have less compliance. So there's less, but these are activated slightly differently in our bodies. They've got they've got similar connections, but the connection with the linea alba is separated by the belly button. So oftentimes we'll check for a diastasis. I would check for your diastasis below and check for compliance there. And that's where we would be looking for improvement as you do your hyperpressive training. But quite often...
Sorry,
yes?
have you got a picture of somebody or a video of somebody doing it at a grade 0 or a...
No, I don't, but it really is when I see my kids do it and they cough, you can see their abdominals just, they don't go in massively, but they just concave a little bit. And it is really their transverse is going like that and just holding the pressure where it should be inside instead of letting it out.
Okay.
Unfortunately, I should take pictures of my clients when they come, so I've got more pictures of things to show people. I will start doing that. They'll not like me for it, but I will. So I have had some clients that have come that have, it's concaved in as well. But the majority of people who've had children or over 30 tend to have it either at a 1 or a 2. It's very rare that I see people as bad as mine was. But I had a diastasis you could get your whole fist into, so hence why it was so bad.
Okay.
So checking for a diastasis. If you are checking for a diastasis, you're going above the line, you're going above the belly button first in the linea alba, in the line here. You get people just to lift their head off the floor a tiny bit, and you're feeling in between the linea alba. It's less these days about the width of the diastasis and much more about what you feel underneath. If your fingers can keep going in and in and in and in into their bellies, then you know the transverse isn't kicking in very well at all, and there's a dysfunction there. If you put your fingers in and they're being expelled, it's also showing us that there is a dysfunction there. So one is it pushing out too much, so it's also not activating the muscles well. What you want to feel is that you've got almost like you've got a little bit of tension behind it, but it's not neither being pushed out or sucked in, so to speak. So you look above the line and below the line of the belly button. So you've got the 2 areas, the supra and the infra area of the abdominals. Okay. So, and there's lots of information online about how to check for a diastasis as well, but you can feel it in your own body, and that really, really helps. So hopefully you've not all discovered that you can get a whole fist into your abdominals like I did the first time I learned how to do a diastasis check. So the next one we're going to do is your pelvic floor. So you're going to do this, you're going to put your hand on your vulva area, again lying down, and you're going to cough. It's the same scoring scale as the abdominal contraction. So you put your hand on your vulva and you cough. What do you feel? Do you feel that your whole vulva area comes out into your hand and takes a long time to go back? Do you feel like it comes out a little bit and goes back in? Do you feel it stays where it is, or do you feel like it moves back up inside you? So again, this is 3, 2, 1, and 0 for the scoring when we score it in hypopressives. And again, you're looking for improvements in your clients as they go through the program with you or go through training and using the rib cage. Okay, so hopefully you all had a 1 or a 2 and nobody had a 3. But if you had a 3, don't worry, we've got hypopressives coming next to help. And again, mine came all the way out. I had such awful prolapses. So mine is now a 1, so it stays where it is, which is what makes me very, very happy every time I do that with clients and with trainers. So the next thing we're going to check is what's going on with their rib cage. So we're going to find a neutral pelvis. So I teach them how to find a neutral pelvis, and you'll have your own ways of finding a neutral pelvis. So you're going to find your neutral pelvis. Once you find a neutral pelvis, I then ask them where their rib cage is in relation to the floor. If once you find a neutral pelvis, their rib cage is off the floor, elevated off the floor, I know that they have a flare in their ribs. So that tells me that they've probably got quite a lordotic spine, and the lordotic spine is coming from their rib flare. So that's something that we're going to work on with the back body breathing in hypopressives. And most women postnatally, and sometimes for years and years and years postnatally, will have a rib flare because nobody teaches them how to bring their ribs back down. So this can contribute to low back pain and thoracic pain and a whole lot of other stuff going on, and also an increased non-compliance in the transverse muscle because the transverse muscle has been completely stretched at the front all the time. It also probably means that they're not mobilizing their rib cage at all, because as you mobilize your rib cage, your ribs will start to find a great natural position again. So some basic tests to test. The last thing is head position. So when they're on the floor, you want them to have the back of their occipital bone on the floor. So if we put our hands up the back of our neck and draw our hands up the back of our head till we feel the bump, we're going to place that on the floor. So we want to have that active stretch through the neck. While like this, our eyes should be looking straight up towards the ceiling. If my clients can't do this without looking over the top of their head, I know that they need a little block. But you do the same check in Pilates. So we're looking for the ears, shoulders and hips to be in a lovely kind of directional line to start with, so that we've got something to mobilize from. Okay, once you're here, soft eyes, I'd like you to feel now like the back of your rib cage is on the floor. The back of your pelvis is on the floor, and your feet are evenly weighted on the floor. And Sue Hitzman, who does the MELT method, has a really great way of talking about this, the spaces and masses. So you've got a mass where your head is, a space where your neck is, a mass where your rib cage and shoulders are, a space underneath your belly button and your lower spine, a mass where your pelvis is, a space where your legs are, and a mass where your feet are, and they should all be evenly weighted throughout. Okay, then here we are going to work on our rib cage. So we're going to take our hands and place them round our ribs with our fingers to the front and our thumbs to the back. So thumbs to the back is important so you can feel the back body movement, and we want them down towards the lower ribs initially because we want to really feel the mobility in the lower rib cage. We're going to inhale, and we're going to inhale through our nose and exhale through a relaxed jaw. And as you inhale, I'd like you to expand the rib cage out towards the side. And as you exhale, I'd like you just to control the closing of the rib cage to really slow it down, to create as slow an exhale as possible. Good. We're going to do 3 like this. So inhaling, widening to the sides, and exhaling, relaxing your jaw and allowing the rib cage to slowly close. Good. And one more. Inhaling wide to the sides, and exhaling and allowing it to slow. So really controlling the exhale. So for the next 3 breaths, I'd like you to start with the widening of your ribcage to the sides, and then I'd like you to bring the breath into the back of your body and try and expand the back of your body into the floor. So we're inhaling and pressing our ribcage out towards the sides and then feeling the expansion of the back of our body in the floor. And as we exhale, we're going to allow that to slowly close, so controlling the closing. As we inhale, we want to make sure the ribs stay on the floor. As we exhale, we want to make sure the ribs stay on the floor. Good. So just a nice, and you really want to breathe as slowly as you can. So a nice slow inhale in and a slow expansion of the ribs in the back of the body. And then exhaling, really controlling that relaxation of the rib cage back down to its central point. Good. And you're going to do another 2 like this. Really feeling that expansion of the rib cage. Now I'd like you to think about your sternum after your next breath. So as we inhale, I'd like you to think about the rib cage widening to the sides, the back of your body widening into the floor, and I'd like you to think about the upper part of your sternum reaching up to just underneath your chin, but just gently, so it's not moving massively, we just want it to move up. So we're not pressing it forwards into a rib flare, we're thinking about it moving up towards our chin. So we've got that lengthening up the way of that, of the sternum, which is going to create this length in the body on the inhale. And then your exhale, again, try and keep the sternum a little bit high as we exhale. So just keeping it a little bit elevated as you slowly close the ribs down. So the sternum is always going to feel like it's open and it's wide on the inhale and on the exhale. This is super important when we come to talk about posture patterns for women and men with pelvic floor dysfunction and posture issues. So do another couple like that. Okay. So it's side of the rib cage, back of the rib cage, sternum, and then the exhale is just allowing the ribs to float back down slowly and just being aware that the sternum is going to stay slightly elevated. So wide is a better word than elevated almost. Good. And at the end of the next one, we're just going to pause for a moment. So, you guys, the next thing we're going to do is do a little bit of a visualization. And this is the way that I get people into the kind of zone for doing the apnea. And it's called a breath reset. And it's tied in with an exercise from Debs Dana's polyvagal theory. So we're going to inhale. And as we inhale, I would like you to think about some place, something, or someone who brings you joy. And the reason we're using this is because the inhale is the activation part of the breath cycle. So it's speaking to the sympathetic nervous system more. As we exhale, I would like you to think about something, someone, or someplace that brings you calm and peace. And the reason we're doing this is because the exhale is what speaks to the parasympathetic part of the nervous system, as does that thought pattern. So we're going to inhale in our joy and exhale our calm. And we're going to do this 3 times. And at the end of the 3rd exhale, I would like you to just pause and do nothing at all. I'd like you to wait in the space between breaths. So 3 breaths. Inhaling your joy to the sides behind in your sternum, and just take your time. Do this in your own time. Even if I'm talking, just take your time. And then as you exhale, it's the calm and just really controlling that gentle closing of the rib cage. And at the end of your 3rd exhale, you're going to close your mouth and nose, and you're going to hold the air out briefly. You're going to relax your face, and you're going to pause, and you're going to listen for your body's own natural impulse to inhale. So we're not going to hold the air out indefinitely in a kind of Wim Hof way. We are going to just wait and listen. And then you're going to do that same exercise again. So exactly the same again. Inhaling in your joy and really visualizing your joy. And exhaling your calm. And at the end of the 3rd one, pausing and waiting and listening for your own body's natural inhale. This is a great exercise for slowing down people's breath who breathe really rapidly. Even my ladies who breathe slowly, breathe much more slowly when they think about this visualization. It's just a great way to calm the nervous system down. And this is essential for pelvic floor health, which we'll talk about too. The reason that we're creating this pause, and I'm getting you to listen for your own natural inhale, is this is the space that we're going to use for the apnea. And we're going to play with the space between breaths. If I have a client who comes to me and they do these 3 breaths and they can only pause for like a second or 2 before they feel they need to breathe, then this is what we work on for the first session and for the first week. We work on creating a longer and longer pause so they get much more tolerant for CO2. There is very little point in taking people into an apnea or an opening of the rib cage, holding the air out if they can only manage a couple of seconds. We want people to feel really comfortable with the CO2 or getting comfortable with CO2 tolerance before we add in the apnea breath. They'll have much more success, and I like to set people up for success and not failure. So this time what we're going to do is try and explore the apnea. We're playing, remember. So we're going to do our 3 breaths, the same thing, inhaling your joy, exhaling your calm. At the end of the 3rd one, you're going to pause momentarily. You're going to close your mouth and nose, and for this whole bit, you're going to hold the air out. And you're going to widen the rib cage towards the sides, the back, and into the sternum, the same way we did when we were inhaling, but with no air coming in. We have lots of residual oxygen in our body, so we're never going to be without air, and you are in charge of when you want to inhale. So you're going to do your 3 nice slow breaths, really focusing on that movement of the rib cage so you can recreate it for your apnea. And at the end of the 3rd one, you're going to pause for a moment, not go into the apnea immediately, and closing your mouth and nose, and then you're slowly going to widen your rib cage to the sides, behind, and into your sternum to create the apnea breath. And practice it a couple of times, guys. So just do this twice through. Kerry, try not to hold your nose. Try and do it without holding your nose these first times. We'll come through to all these things in a bit that you could maybe use as interventions. So we open the rib cage really, really slowly. And the reason we open the rib cage really slowly is because we are working with slow twitch muscles primarily. Your pelvic floor and transverse muscle are made up mainly of slow twitch fibers, between 69 and 75%. So if we were to open really quickly, we would not have the activation of the majority of the muscles within the pelvic floor. So we want to open really slowly because that slow gradual movement and opening is helping. Also, our diaphragm has got loads of slow twitch muscles in it. Our transverse muscle does, as does our pelvic floor, our multifidus muscle, and quite a lot of the other muscles in our body that are for stability. They have to be like that because they're on all the time. So if they were all fast twitch muscles, we'd all be like falling down all the time, unable to do anything at all. So how did you all find that? I have lots of interventions to help make it much, much easier for you if you need it as well. So I will go through all of them because you'll need them for clients. How did you all find that?
I have a question.
Yes, Dorothy.
The preference, or how do you direct the exhale? I remember that you said take it through the exhale mouth. So, but now when I'm doing it, I'm starting to realize I do all sorts of variations with my tongue. So how should I place my tongue and my jaw on the exhale? Any directions on that?
So the tongue, if the tongue is in its natural resting state, it's resting gently against the roof of your mouth. However, if you find that you're tightening your tongue in your mouth, then you want to relax the tongue down. And that relaxing of the tongue down will help to relax the neck and the laryngeal diaphragm a little. So yeah, direction. But naturally, our tongue should naturally hang out at the top of our mouth most of the time. But if you're holding tension, relax the tongue because it will relax everything else. Yeah.
I have a question too.
Mm-hmm.
I think, unless I got this completely wrong. So you breathe out.
Yep.
And you empty your lungs, and your sternum is slightly, the top of your sternum is slightly up. Your ribs are flat and wide. Then you kind of imagine you're breathing in again and getting that sort of, doing that even more, widening the ribs even more.
No, your ribs will be closed, Deborah. So you've exhaled. So you inhale, you
Inhale,
exhale.
and then you exhale, and then you don't inhale again, but you imagine you are. Do you?
You don't really need to imagine you're inhaling. I mean, it's one way you can get the feeling of opening your ribs. There's ways that we can do it, but what we're actually doing is just widening the rib cage.
Widening the rib cage.
Yeah,
right.
widening the rib cage.
But when you come to breathing in, your rib cage is always already wide.
Yes, it's already wide. So then all we're doing is filling the lungs, because we don't need the rib cage to fill the lungs. The lungs will work whether the rib cage is closed or open.
Okay, right.
It's quite it's like, to start with sometimes. Don't worry, I've got lots of tricks to help. So we're just going to do it as a very holistic way just now, and then I'm going to bring in lots of things as well. Any other questions about how your apnea was for you just now when you did it?
I found it quite hard to keep that breath slow when you're coming back in after holding. Yeah, I found that hard. And also just making sure that I'm not holding tension in my shoulders, letting tension creep up there again.
This becomes less of a thing when we start to add in the arm positions, but when we've got our hands around our rib cage, it kind of, because of the position we're in, you get that creep of tension into the shoulders. So I wouldn't worry too much about that at this stage at all.
But the slowness of the breath coming in, I'm finding I'm wanting to
hold the apnea breath for a little less time. So don't hold it for quite so long. So you want to be able to hold it so that you can easily take that next inhale in, because we're going to run it like a flow. So we're going to do our 3 breaths, our apnea, then another 3 breaths and another apnea. So we want to be able to come straight back into the breath cycle again. So hold for just a little less time, Rachel.
Right, it's quite interesting because as a singer as well, you've got like split second to take your breath.
Yes.
You know, maybe that's like my breath is, I've got to breathe quickly because then then
your next phrase is coming. But that when you think about it, what that's doing is it's not giving you that full extension of the pelvic floor each time you breathe. So you do have the really long exhale where everything is drawing back into the center, but you're never getting that. So you're never releasing, you're never getting that full stretch of the pelvic floor when you're inhaling, when you're singing.
And I think that's why with singers, a lot of the time people talk about, that when you take your breath in, it is the release, but it's so fast. And that's why I think people talk about allowing the breath to cut, like that belly breathing thing, or breathing in between your legs, because you've got to release really quickly.
Agreed. It's the same with people who play wind instruments as well. There's a huge pelvic floor issue with people who play wind instruments like saxophone and things like that as well, because of that as well, that quick inhale for the long exhale. Yes, Vicky.
Is it normal? So in the apnea, I felt really strong internal pull, like real tightness.
Yes, so quite often when you get the apnea, so different people feel it in different ways, which is why I wait till you all talk about it before we talk about it. So some people will feel just a gentle lifting of the pelvic floor. Some people will feel no lifting of the pelvic floor, but will feel an expansion in their rib cage. Others will feel a pull all the way through the center of their body. And everybody's bodies react slightly differently. But as long as we're widening the rib cage during that time when we're holding the air out, we will be getting that drawing up of the pelvic floor. And I'm going to explain why in a minute. But yes, Vicky, quite often people as well will have listened to me say, don't draw in from your abdominals, or don't draw in from your, it's not the same as the Uddiyana Bandha. And they'll go, oh, I've been trying really hard not to suck in my abdominal muscles. It might feel like your abdominal muscles are pulling inwards and upwards. And as long as that's coming because you've opened your rib cage and not because you've tried to open your rib cage from your abdominals, then that's fine. But a lot of people, when they're first trying to open their rib cage, will try and they're like, oh, I can't really do this, so I'm going to use my abdominals to push my rib cage open, and that's the wrong way around. And you can see that in people when they do it. When you watch your clients, you can see them doing this kind of, it's like a jerky movement, and you can see their abdominals kicking in first before their rib cage widens. So as long as your rib cage is widening first, Victoria, then it's all good.
Okay, so for somebody, like I found that really hard, and my abdominals are kicking in your rib cage.
Yeah.
Does that mean that is that really bad?
No, no. I'm going to talk about how to make this a lot easier for you. There's honestly, it's a really weird movement pattern. So I've got lots of tips and tricks that we're going to use to find our way into it. So what did you find, Candida, when you did it?
I'm finding very little movement in the rib cage. I'm really trying to envisage it widening, physically trying to do it, but all I'm getting is the abdominals kind of widening first.
Yeah. So we're going to go through this. So I'm going to go through a couple of tricks. We'll go through a couple just now before lunch, and we'll go through some more after lunch. So you feel a little bit more like I've got you supported and I can help you with this. So it's all right. It's okay. I will go through all of them. So we'll go through a couple just now, and then we'll go through some more after lunch. So I'm going to get you all to do all of them, so you can have a feel. Did anybody have anything else they wanted to say before we do this?
Yeah, only that when I was trying to do the apnea, increasing my rib cage, I felt it in the base of my throat, like there was pressure there. Is that good?
Yes. So what's happening? So a little bit of physiology, and then we'll go into some tricks and trades, and we'll do another extra 5 minutes before we break for lunch. So when we open our rib cage during the apnea, if we think that this is a closed pressure chamber at this point, there's no air coming in, there's no air going out. So we can forget about the decrease and increase in air in our lungs and the pressure in our lungs. Everything is the pressure is there. And we can't change the pressure, we're just going to be moving the pressure about. As we widen our rib cage, our diaphragm, central tendon, draws down, and the ribs stretch out, and the muscles stretch out. When it does this, it draws the epiglottis down. So the laryngeal diaphragm draws down as the thoracic diaphragm draws down. Because we've increased the space here, then that means that we have to decrease the space, that our body will naturally decrease the space or decrease the pressure in the lower abdominals. So as we open our rib cage and the diaphragm draws down, we increase the pressure here, because volume to pressure, all of the physics stuff. And what happens then, as the pressure is decreased and the pelvic floor is lifted, because what happens is a parietal fascia that goes all the way around then draws the pelvic floor up. So we have this increase in pressure when the diaphragm pulls down. The laryngeal diaphragm also draws down, and the pelvic floor lifts up because this area is being decreased. So we are playing with pressure. We're increasing here, decreasing here, and the increase here is because of this kind of drawing of, it's like a plunger drawing the neck down. Some people feel it really strongly here when this happens. And if you feel it really strongly, you find when you come to take your next breath, you're doing a breath, which quite a lot of clients do. Just before you breathe, you can kind of do a little swallow just to release the laryngeal diaphragm and the epiglottis a little, or just move your neck from side to side. This also works as well. Or just hold the apnea for a little bit less time, but some people just get a phenomenal draw on the epiglottis when they do this, and so the little swallow really helps. So that's kind of the physiology of what we're doing. We're increasing pressure here, and by increasing pressure here, our body in this closed chamber has to decrease pressure somewhere else, which is the bottom part of the pressure chamber. So that's what's creating the visceral traction up. It's the drawing down of the diaphragm. So it's all pretty cool and weird. So let's do a couple of kind of drops into what we can do to help clients find great apnea. So the first one is this. I'll come close to the screen and talk you through this. So I'm going to get you back to lying on your backs, finding your neutral pelvis, your rib cage heavy on the floor. Good. Okay. Excellent. Find your head position. Okay, so this time what we're going to do is just, we're going to do our 3 nice slow breaths the way we were doing. And at the end of the third breath, when you close your mouth and nose, I would like you to relax your abdominals. So quite often, not being able to open the rib cage is because you've had such great abdominal compliance that the transverses come all the way back and the obliques have come all the way back. And when you try to open your rib cage, they're held in place by those muscles. So we need to release them a little to give us space to open our rib cage. So we're going to try this one first. So 3 nice slow breaths. Opening to the sides, behind, and into the sternum. And at the end of your third one, so just nice and slowly working through it, you're going to close your mouth and nose, and in that moment of calm, you're going to release your abdominals. Good. How did that feel, Candida? Don't worry, I've got many more.
Sorry, I'm on mute. That gave me a little bit more movement in the ribs.
Yeah, so I suspected that there was a little bit of extra tension there. So
Yeah.
I've got loads of other ones, so don't worry. So the main muscle that's going to help, that's actually helping us to open our ribs is the serratus. So that's this muscle here. So we're going to encourage a little bit of extra movement out the serratus. The serratus is a helping hands muscle here. And it is that muscle that is contracting to draw our rib cage apart. So that's the functional and the intercostals are also, one half of our intercostals are widening, the other half are closing to also open our rib cage. So what we're going to do is try to get into that serratus intercostal engagement. So we're going to do a visualization. We're going to do the same thing we just did. But at the end of the third breath, we're going to close our mouth and nose, we're going to pause, release our abdominals, because it's always good to do that to give us that little bit of extra movement. And then I'd like you to visualize sniffing a flower with a blocked nose. So that kind of idea will activate the serratus a little. So for some people, this can remember, we're not taking in any air when we do this. We think about, you've got a terrible cold, you cannot breathe through your nose, but you're going to think about sniffing a flower in that situation. This might work better for you, Kerry, than holding your nose. We'll see. Think blocked nose, no air coming in. And some of these work for some people, not others. So don't be disheartened if it doesn't work for you. I have others. So what we start trying to do initially for people who are struggling with opening their ribs is initiating the movement so that your body knows what the movement feels like. And once it knows what the movement feels like, then it becomes much, much easier. So, but initially we're trying to initiate. So the next one I'm going to get you to try is this. Now I'd like you to imagine that you have a glass with milkshake in it, and at the bottom of the milkshake is a strawberry, and you want to get the strawberry out of the glass with a straw. Now this is a sucking technique, but it is not like sucking like it's, you've got to take air in at the same time to get the strawberry up. It's the pressure of the air that's pulling the strawberry up. So you're not going to take in any air. You're going to do 3 nice slow breaths. At the end of the third one, you're going to close your mouth and nose. and then thinking about doing this, and you're making the movement with your mouth and things to do it, but you're not taking in any air while you do it. So it's almost, and really visualizing that sucking the strawberry out of the glass. It can be a cocktail, it doesn't have to be milkshake. Some nice apneas here. How is that one for you?
I have a question. Is
Yes.
that sucking the straw in itself meant to be moving the rib cage, or do you do that first and then move the rib cage?
So it's supposed to instigate the movement of the serratus. So when you do it, see, if you just do it now without even thinking about opening the rib cage and things, if you just, without thinking about it too much, just think about the idea of having a straw and trying to suck the strawberry out of the bottom of a glass. And you do that, and you should feel that kind of involuntary movement that happens in the upper ribs where your serratus is.
Yeah, do a bit, yeah.
Yeah, so that's the movement pattern that we're looking for. So that's part of the movement pattern of widening our ribs, comes from there. I've got another one to do before we break, and we'll break at 1:45. But I've got some more if we need them as well. But the other one is very, very weird that I'm going to give you to do. And this is definitely just to be done to teach your body that it can open its rib cage without breathing. So I've written these all down in your sheets as well, so you'll have them all. So what we're going to do is this. We're going to use a recoil movement to show your body that it can open its rib cage. So we are going to inhale, and we're going to inhale, and as we exhale, we're going to keep our rib cage open. Then we're going to inhale into our already open rib cage, and we're going to exhale again, keeping our rib cage open. Then we're going to inhale again for the third time into our already open rib cage, and then we're going to exhale, and as we exhale, we're going to really close our rib cage. You're going to really close it down. So you're not going to let it gently close, you're going to squash it down, and then close your mouth and nose and allow it to widen. So you want to think about the activation being more like a recoil, so your body can feel what it feels like. So in your own time, nice and slowly for the first ones, but for the last one, a real kind of close the rib cage. So it's so that we really contract the muscles so they know how they activate to open. Keeping the rib cage open each time. And we're teaching our mind that we don't need to inhale to open our rib cage. Okay. How did those all feel for you guys before we break for lunch? Candida, how did that feel for you?
I didn't think I was getting it so much. Sorry.
That's okay. That's okay. It's going to take practice.
Yeah, it wasn't as tangible as the other
ones.
The other ones, no.
I don't like it because it's a forced exhale, and I don't like any forced exhales when it comes to pelvic floors. But for some people, that means that
my breathing is not as good as it should be anyway. Which is probably why that last one didn't work as well for me, I think.
Yeah, I think it's a real thing with our brains to let go of the fact that we think that we need to use our lungs to inflate the rib cage, and this can take a whole session and sometimes 2 sessions with clients sometimes. So it's not that you're never going to get it, it's that it's going to take us practice to get you there. But as long as you were starting to feel that activation into the serratus, that's what I'm looking for. And we'll do some more practice when we come back after lunch. So this is I'm not done with you yet, and I have clients that it takes a while for them to get the full, the maximum. They tend to be the ones that get the most amazing apneas as well when we're finished. So, slowly catch your monkey sometimes. So how's everybody else getting on?
I found the first two variations okay.
Yeah.
The second one, my ribs were getting bigger. You know, I was expanding more, but I found it difficult to kind of push them down. I didn't, you know, I wasn't sure what I was supposed to be feeling, and then my tummy started kicking in, and even my pelvic floor was there, and it was just like it was all going off, you know.
The one where we open our ribs and keep our ribs open is primarily for people who really cannot get their head around the fact that you need to inflate your lungs to be able to breathe. So it does create that disassociation between the two. But again, the forced exhale at the end is one that I really don't like doing with people because it does create so much downwards pressure. And what we're looking for in hypopressives, the way I teach it, is we're looking for an active stretch. And the active stretch is important because that slow widening of the rib cage is what's creating that slow, gradual lift of the pelvic floor. There is another method that's taught by UK hypopressives where they work on that recoil factor all the time. So there's no active stretch. They do a much quicker breath. So it's a 2-4 breath, which we'll practice when we come back because I like you to try everybody's methods. It's a 2-4 breath and there is no active stretch. It is inhale, exhale, inhale, exhale, inhale, exhale, pause, allow the rib cage to do what it's going to do. So it requires a recoil action and it's a much more of a forced exhalation. It's not a natural exhalation. It's much more of a exhalation. And so for me, that just goes against everything to do with the pelvic floor. But then I do wonder, because they learned hypopressives at the same time as me when it was very much in Spanglish, and I think there may have been a cross, you know, I went away with more questions and answers the first time as well. So, not everybody has a mother-in-law who's Spanish though, so, you know, I just had benefits from my learning. Have a practice of this during your lunchtime as well, when there's not the pressure of people staring at you, you know, and me looking at you, because sometimes that really helps as well. Don't eat too much for lunch. I suggest eating lunch, a light lunch, so that we can come back and move. I'm not going to do what the Spanish do, where they feed you hundreds and hundreds of food at lunchtime and then make you move your ribcage about afterwards. So we're going to come back at past, so a slightly shorter lunch break, so we can get everything done, if that's okay with everybody. Is 45 minutes good? Okay, good. Okay, excellent. So I'll see you all at 1:30, and we'll crack on. We're going to come back to the apnea and then we're going to start layering it in. We'll have lots of time to practice, don't worry. Okay, all good. Mwah! See you after lunch, yeah?
Thank you.
Take care, guys. Hello, everybody arriving back. So, has anybody got any questions? We're going to do some release work for our rib cage in a moment, and also going to use the bands to help with the feeling. Just for these are other things I use with clients. But anybody got any questions after they've pondered this during lunch? Oh, good. I'm not sure if that's a good thing.
Abby, I was just going to ask the exercise we just did. It was only because I was reading afterwards. I didn't do it with my ankles dorsiflexed.
Yeah, don't worry, we're not doing
Doesn't matter for that.
activation yet. We're just focusing on the apnea.
Just on that. So okay, it doesn't need to be done at that point. It's just feet down as usual. Okay.
Yeah, so what I do next is we're going to layer in a bit. Once we've had another shot of the apnea, we're going to layer in the first exercise with all the principles involved supine, and then we'll layer in the other ones as well.
Okay.
I have a question just about, you know, when you did the breathing assessment and you put your hand between your legs, obviously, same for men, just obviously, do they have to?
They have to get towards a bit more towards the perineum.
Perineum,
so they're holding on towards it, but yes, the same for men,
yeah, thanks.
I've had quite a few men with who have connective tissue disorders like EDS, hypermobility, who have issues with prolapse, so anal prolapse, rectal prolapse. So that can be quite a common thing with that as well. And again, it's connective tissue issues for them. And sometimes pressure, sometimes the other thing that really happens for men with prolapse is when they've been men who've lifted really, really heavy weights and used a belt to breathe into, rather than, so that what they've done is they've done that belly breathing every time they've lifted a weight. So they've put pressure down the weight as they've been lifting their weight. And that's created an imbalance and then a prolapse as well. So that's the only other time I've come across it. I've done quite a lot of workshops with the CrossFit people around here to try and re-educate people about lifting and breath work, which is important.
Yeah, I've actually found a lot more diastasis in diastasis rectus in men that I teach than in women. And a lot of them, and I've had this discussion about, you know, when they're taught that when they lift heavier weights that they create this pressure outward. And
yeah, it's called bracing. So they do a brace maneuver. They put a belt round, or they do it without the belt. And what they do is they, as they lift the weights, they push out into their abdominal area. So what they're taught that what this does is it creates stability for their spine, because what they're doing is they're expanding the abdominals, and that should to create a co-contraction across the whole abdominal area to create stability for their spine. And in some ways, it probably does. But it's not a positive thing for your body to do. It might support your spine, but it's not going to support your pelvic floor, and it's going to lead to just an enormous amount of pressure, which is eventually going to work into a diastasis or a prolapse.
Okay. And I have another question, because I just quickly went down and checked a couple of things on my daughter, who is 18, and when you cough when you're standing up, is that different to when you're lying? So when I was lying down, I felt that the upper abdominals drawing in, but the lower's pushing out. When I'm standing up, it's more of an all in. When she was standing up, obviously, I watched her cough and everything drew in nicely with the abdominals. But when she had her hand between her legs, she was dropping down on the cough. So what I'm saying is the abdominals were drawing in. Is it different when you're lying down, standing up?
So there's more going on when you're standing up with your body. Your diaphragm is not just working as a breath organ at that point. It's also working as a stability organ. So it's also there to create stability in your spine. So your diaphragm's doing many different hats the minute we stand up. So this is why we always check lying down. So everything, the diaphragm's relaxed, the abdominals are generally reasonably relaxed. So I generally test lying down, unless people can't lie down, and then I test them sitting. And again, they've just got less work going on than the rest of the postural chain.
Okay. And would you ever get that? So I'd have to try her lying down. Would you get that drop down into the vulva when you cough, but the abdominals coming in?
Yes, so there's the potential for that, but I'm actually wondering what her breathing's like normally, Rachel, whether she's already starting to get that teenage anxiety breath where she's predominantly using her upper chest area. Pelvic floor dysfunction doesn't suddenly arrive when we are perimenopause or pregnant or postnatal. It's usually something that we've been working on since we were teenagers.
It's very and also she's really hypermobile, and also she's scoliosis. She has one leg actually not functionally, structurally shorter than the other.
So that will be having an impact on her pelvic floor. So I would be definitely just observing what her breath. I mean, when I used to teach high school kids, when I started doing all this journey and I was still teaching high school kids, I started to really watch their bodies, and you could see them come in first year or in the first time in high school and secondary school. If you're in England, it's slightly different than the Scottish education system. They'd come in and they'd all be like, yeah, and they're really upright, really open, and great posture because they've been sitting on the floor in primary school and not sitting at desks so much. And then they come into high school and they'd all start to collapse in here, and they start to hide their emerging breasts, and there's this whole thing that starts to happen with women's bodies and boys as well, you know. So I would just check, get her doing hypopressives and see what the changes are, Rachel, to be honest.
I'll try. She's 18. She don't want to.
I don't know. I do workshops with the teenagers at the high school here now, and the girls are really open to it, you know, because it's future proofing. It cinches her waist. One of the big sellers for young girls is the fact that the more they get this apnea breath, the smaller their waist gets, because they've got that real great coactivation. That's how they sell it in South America to so many people. You know, it lifts your pelvic floor, reduces your waist. And so the teenage girls really like that, so they try quite hard, you know, and it's really good for exam tension and stress as well, you know, and for job interviews and things, just being able to breathe. So I sell it from that whole kind of holistic point of view, not just the pelvic floor for them. Yeah. Good luck though. I know I've got like a 13-year-old boy and it's a murder at the moment. And one about to be gonna have them both at the same time. Boys are murder. I think girls are murdered too. They're also lots of fun, I have to hasten to add. So we are going to start back with our apnea breaths. If anybody's got any questions, we're just going to go through a quick question session, and then we're going to do some release work for your rib cage, which may also help your apnea, because quite often we're holding a lot of tension under our ribs. Any questions? Okay, right, let's do this then. So this is nicer done lying down. You can use a ball, like a massage ball, or you can use your hands. So I'm going to teach you both ways, because not everybody has the things, all the things and all the toys all the time. I'll take my microphone with me so you can hear me. That'd be a good idea. Okay, so we're going to come to lying down. And we're going to do a test first to see how your rib cage is and your diaphragm, and see how much mobility we've got underneath our ribs. So what we're going to do is we're going to use the left side of our rib cage, not the right side initially, because the right side for most people has their gallbladder. So there's going to be a little bit more restriction underneath the right side of the ribs. What we're going to do is we're going to, on an exhale, so we're going to inhale, and on an exhale, we're going to see how far we can get our fingers underneath our rib cage. So we're looking to see whether we can't get them under at all, whether we can get them under a little, whether we can get them under quite comfortably, but not totally comfortably, or whether we can actually play our rib cage from the other side. So you've got three choices here. So we've got three. A three is if when you try to do it on an exhale, so your diaphragm's moving up. A three is if you can't get your fingers under at all, it feels rock solid, which is what mine used to feel like. A two is if you can get them under a little. A one is if you can get them pretty much all the way under, and a zero is if you can basically play your rib cage from the other side. So what we're looking for to see is whether we have really tight adhesions between the pleura and the fascia, the diaphragm and the ribs. So we're looking to see whether our diaphragm is free to move when we do the apnea breath and when we do the breathing, or whether our diaphragm is like stuck hard to the edges. So it's going to be much, much harder for us to open our rib cage because it's kind of stuck tight with a tight diaphragm that's not used to mobilizing. So we're feeling underneath your ribs. And left side, not right side. So inhale, exhale, feel. Once you have a gauge of whether you're a 0, a 1, a 2 or a 3, whether you can get your fingers under at all, it doesn't matter whether we can get them all the way under or not, we can still always benefit from a little bit of massage. So if you've got a ball, what you're going to do is put the ball in your solar plexus, not pressing down hard on the wee bone there, because the wee bone there will like hurt, well, it makes you feel icky actually. And then you're going to take the ball, and as you exhale, so you're going to inhale, and as you exhale, you're going to roll the ball underneath the edge of your rib cage. If you feel a bit that feels a little bit tender or tight, you're going to pause the ball there, just holding it gently into the tight area, and take a nice inhale, exhale into the tight area, allowing the fascia to hopefully melt a little bit. Then we're going to inhale, exhale, and continue our run all the way down our ribs. If you don't have a ball, you can use your fingers. So instead, you do an inhale, exhale, and as you exhale, you just massage all the way underneath your ribs, which is also really nice. If you reach a tight bit, you do the same thing. You just hold it gently with your hands. You inhale, exhale, allowing the fingers to sink in a little bit further. And then you inhale, exhale, continue your journey around your ribs, starting with the right side, the left side. Once you've done that, and take your time to do it because it's a really nice exercise. Once you've done that side, you're going to swap to the other side, bearing in mind that about halfway down is your gallbladder, so that might feel tender. So just go gently past the gallbladder. So again, it would be exactly the same, starting from the solar plexus, Inhaling, exhaling, rolling the ball underneath, or using your fingers to massage as you go round. Or doing a bit of both, you know. If it feels tender, my gallbladder always feels tender because I did a terrible thing when I was first incontinent. I didn't drink any water, so I gave myself gallstones. So you need to make sure that you have enough fluids in your body all the time, all the way around. And you can come, your rib cage comes all the way around your body, so come as low as you can around your rib cage, releasing it as far around as you can. And I use this quite often as a warm-up at the start of a class, just to get people's ribs nice and warm before we begin the session. And I do quite a lot of breath work at the beginning of class too. Once you've done that, you're going to try your apnea breath again. So you're going to take your 3 nice slow breaths. And this time I'd like you to do a visualization again. So this time the visualization is going to be that your rib cage has a fulcrum point at your solar plexus and a fulcrum point at the back, where it's going to move like this, like 2 bucket handles. So if you imagine a bucket on the beach, and usually it's got 1 handle, but this one's a random bucket that's got 2 handles. And the handles are going to open to the side as you do the apnea. So you're inhaling, they widen. Exhale, closing the handles. Inhale, widen. Exhale, close. Inhale, widen. Exhale, close. Close your mouth and nose. Release your abdominals a little. And then think about the bucket handles widening up towards the side again. So 3 nice slow breaths. You can think about joy and calm if you would like to, if you'd like to add in a bit for your nervous system, or you can just breathe nice and slowly. Inhaling through your nose, exhaling through a relaxed jaw. You are also welcome to practice inhaling and exhaling through your nose if you can keep your jaw relaxed. It puts a different kind of kilter onto things when you do it that way as well. Good, so 3 nice slow breaths, and then your apnea. And think bucket handles. Now the next one that's really nice to do to help with the apnea breath as well, once you've finished practicing that one, is to use your hands on skin. So what you do is you do your 3 breaths, inhaling and exhaling. And then when you do your apnea breath, you move your hands up in the direction that you want the rib cage to move. So they come from your belly button or abdominals up and to the sides, like you're opening like this during the apnea. So what we're doing is we're encouraging that movement with a tactile sensory touching of the skin, which is actually really nice. So you can have your hands around your rib cage while you breathe. So you can do your 3 breaths. And exhale, releasing. And then when you come to do the apnea, pause, close your mouth and nose, release your abdominals a little, and then as you widen your rib cage, using your hands to encourage the movement, which sometimes really helps with the sensory perception. Nice and slow with the breathing, and try not to overthink it. So the big thing with a lot of my clients is that they start to really overthink this apnea section. I like to think about the apnea section as the icing on top of the cake. We're getting so much from just the breath work alone that we don't need to place all the emphasis on the apnea. We're going to have lots of time to practice. So try to feel what's going on inside your body and feel the rib cage widening and closing. Now the other thing, so once you've done that, take your time to finish that nicely though. The other thing that we can use is a band around our rib cage. So we can either, like, if my clients have got that don't have bands, but they have bras that they can click at the back, then I get them to take it to one tighter so they can feel it around their rib cage, which is a nice way to do it if they don't have a band and if they wear that type of bra. I would be scuppered because I don't. Then what we can do is we can come to a sitting position. And sometimes, and this is, although we think that lying down is easier, quite often I've had a good few now clients who can't find the apnea lying down but can find it in other poses. So I never get hung up over them not getting it in a lying down position, because sometimes it's actually easier for them sitting or standing. Weirdly, everybody's body is so different. But what you do is you tie the band around your rib cage so you can feel it all the way around. So you've got this proprioception. And this way we don't have to have the hands around the rib cage anymore. We can relax them. So we have a bit more relaxation through the shoulders, which can also help with the apnea initially as well. So we can either try the sitting or standing. I'm sitting because otherwise my head will. We'll try both. We can try both and see how it feels in your body, because we're going to come to do the apnea standing shortly too anyway. So once we're here, just a little bit of thinking about observing how our body is, making sure if you're sitting right on your sit bones, and making sure if we're sitting that our rib cage is over our pelvis. And we're going to talk about that in a little bit more detail in a moment, but just generally over your pelvis just now. And we want to also think about having our head on top of our shoulders. So making sure we're not forward facing with the head. Eyes gazing straight ahead, chin horizontal to the floor. We're going to do 3 nice slow breaths again, just the way we've been learning. And at the end of the third one, you're going to pause, close your mouth and nose, and just allow the rib cage to slowly widen. It is an activation. So you can think about the idea of the bucket handles. You can think about the sucking the straw. You can think about the smelling the flower with a blocked nose. And just how this feels now. The diaphragm is also now working as a postural muscle. It's okay, Vicky. It takes time to feel this sometimes. And sitting, to be honest, for the majority of people is the hardest position to do. And we're going to do a multitude of positions for you to try out in this next part of our sessions. And there will be one that fits with you much better than the others. But that doesn't mean we avoid the sitting one. I have everything on SoundCloud. And my supine ones has thousands and thousands and thousands of listens. And my sitting one has 25. Nobody likes the sitting pose, which is just, so I make everybody practice it all the time. But yeah. Okay. So Victoria, you're getting cramp.
No, it's just really stuck under my right side of my ribs. It's like solid mass when I was massaging it, and so in the sitting, this is why I'm not getting anything.
We're going to try standing just now and give you a shot to standing, because you get a longer line when you stand. Yeah, if you've got real tension underneath with your pancreas and your gallbladder, then that can really affect the way that your rib cage operates as well. So just doing that gentle massage every day can really help just start to release any tension under there.
It's a bit tricky to know because my body is not my normal body.
Yeah.
And also I get a lot of swelling in my xiphoid process. So then all the tissue around here.
Yeah, will get inflamed, yeah.
So my disease is not under control. So it's a bit hard to judge what's real.
Yeah. Just being gentle with yourself, Victoria, while you're learning is important here. Yeah. So let's come to standing once you've tried sitting, and we're just going to try it standing. We're going to come back and look at the standing pose in much more detail, but I'd just like you to have a little shot standing as well. And then we're going to build the pose on the floor with plenty of practice for the apnea. So same thing here. We want to, I'm just going to give you a rough idea. So feet hip distance apart, knees soft. We can talk about foot position in a minute, but try and keep them straight. A neutral pelvis, rib cage stacked on top of your pelvis, shoulders nice and relaxed, and head balanced on top of your shoulders. And then try here, 3 nice slow breaths. You can put your hands around your rib cage if you'd like, or keep it so you've got the band. It's entirely up to you. And just really feel that, really feel the movement of the rib cage. The good thing about standing and sitting compared with the floor is you can really observe and be aware much more of the back body breath. We are kind of restricted when we're on the floor with the back body breathing. So think about the lower ribs, the back of the body and the sternum. And as you exhale, think about that just slowly reversing, just keeping sternum slightly elevated. It doesn't have to be held up there statically. It's just being aware that we want length in that anterior chain. And thank you for Victoria for reminding me what the word xiphoid process, because I keep forgetting it today when I'm trying to say don't press the xiphoid process because it makes you feel nauseous. I'm so many words I keep losing at the moment. I'm sure they'll all come back. I'm told they'll all come back, so that's all good. So once we've done that, how did those 3 different positions feel? We are going to do many, many more, but we're going to start building the first pose in a minute. How did you all feel?
Much easier in standing.
Yeah, some people do. Yep.
Agree, yeah, definitely more easy in standing.
Good. Hatefully, I'm going to be building the first pose on the floor so I can talk through all of it, but we will get back to standing, don't worry. We're also going to get into some when we're going to be inverted, which might actually favour some of you much, much more too. Everybody has a different response to different poses. So I used to say, oh, you'll really feel the apnea in this pose, and I don't do that anymore because some people just can't feel that at all there. I don't know what you're talking about, Andy. So let's start building the first pose on the floor. So we're going to come back to the floor, lying on the floor, and we're going to work through the first pose, building in with the apnea, and just getting lots and lots of practice for this rib opening as we go. So we're going to come to lying on our backs again. Knees bent and feet flat on the floor. And the very first thing you do as you arrive here is to find your neutral pelvis. Once you find your neutral pelvis, you want to find your rib cage heavy on the floor. If you have a client or yourself and you have a really pronounced forward flare in the ribs, it's a nice idea to put just like a folded t-shirt or something underneath the back of the rib cage, just initially for people to start thinking about that tactile drawing down of the rib cage towards the floor. The back of the head is on the floor, or the occipital bone. The eyes are looking up towards the ceiling, and we are relaxing our feet. So we don't want any tension in our feet. So the first thing we're going to do is start building our active stretch. So what we're going to do is we're going to have our legs hip distance apart and far enough away from our body that when we go to dorsiflex our feet, it feels comfortable. So if they're really close up, you'll start to feel a real strain up the front of your leg quite quickly, and we're going to be holding this for a while. So the further away the feet are, and still kind of almost like a 45-degree angle usually works with people, but you know, go where feels good for you. What we're going to do is we're going to gently dorsiflex our feet, and I'm going to get you to put them back down again. And I'd like you to close your eyes, or gently, partially close your eyes, and pull your feet up again. And just feel, I want you to pull them up fully this time. We're not going to do it for the whole time. And I'd like you just to feel where you might feel that in the rest of your body. So where are you feeling that in your body? Do you feel it in your calves? Do you feel it in your hamstrings? Do you feel it in your shins? Do you feel it in your abdominals? Can you feel the kind of progress of that stretch through your body? Then we're going to put the feet back down again. The reason that we're dorsiflexing is 1, so we get that connection to the deep transverse muscle, the connection through the fascia chain from the big toe to the back of the tongue, and 2, because as we dorsiflex, we stretch, lightly stretch, the posterior fascial chain. So what we're doing is we're just going to pull, this time when we do it, we're just going to dorsiflex to the point where we start to feel the activation of the muscles. It's like a dimmer switch going on. We want to just have the lights on in the room. We don't want to have them fully on, like really bright. You want to also have nice relaxed toes, so make sure you're not tensioning your toes when we pull up. Okay, so now holding this position like this, you're going to do 3 breaths, taking your time, and then an apnea. So we're going to get lots of practice of this. So you can have your hands around your rib cage, hands by your side, wherever you feel most comfortable. 3 nice slow breaths. Inhaling through your nose, exhaling through a relaxed jaw, or inhaling through your nose, exhaling through your nose with a relaxed jaw. 3 deep slow breaths, thinking lower ribs, back of my ribs, sternum. and then allowing it to slowly close. And at the end of the third one, you're going to slowly widen your ribs. The slower we widen the ribs, the more activation we get with our pelvic floor. Okay, so what we're going to do next is add a little bit more active stretching. So we've dorsiflexed our feet, so the dimmer switch is coming on. Now I'd like you to imagine you've got 2 marshmallows underneath each heel, and you're squishing your marshmallows into the floor. So it's again just a gentle thing. We're not pounding them into the floor, we've just squished them flat. Then I'd like you to think about drawing your heels back towards your bottom, but with no movement. So your sacrum is staying where it is, it's grounded, and your heels are staying where they are, but you feel like you want to start that movement of the heels back towards the sacrum. You should feel now that the calves are switching on a bit more, the hamstrings are switching more a bit, you might get a bit of adductors as well. And now holding both those positions, both those active stretches, we're going to do 3 nice slow breaths again and another apnea. So taking it super, super slowly, inhaling and exhaling. And each time you breathe, you're activating your pelvic floor, remember, without even thinking about it. So each time you widen to the sides, behind and into your sternum, you're getting that stretching out and also a little bit of a descending, but not much. And then as we exhale, we're allowing everything coming back to a resting place. And then when we do our apnea and start widening our ribcage, the fascia inside our abdominals is drawing our pelvic floor up as our diaphragm's being pulled down. Good. Once you've done your 3 breaths and your apnea there, we're going to do the same thing again. So you can rest your feet for a minute. You can grab your wee Pilates ball if you've got one, because it can sometimes really help with this bit to start with folk, just to keep this active stretch going the whole way through. You can use a book or a block or anything really for this as well, or just nothing, just feeling it. So what we're going to do is back to your neutral pelvis, ribcage heavy, back of your head on the floor, everything evenly weighted. Lightly dorsiflexing the feet so we feel that dimmer switch going on, squishing our marshmallows, drawing our heels back towards our sit bones, and we're going to either have a ball between our knees or just imagine holding one there. You can just think about holding one there, you don't have to have the ball in place. So all we're doing is visualizing, legs are still hip distance apart, you're not squeezing the ball, not just now anyway, it's an exercise for another moment. We're just holding the ball gently in place. And what we're doing there is we're activating these adductors a little bit. These adductors are super important. The adductors feed into the pelvic floor. The adductors then, through fascia connections, connect to the obliques on the other side. So that means if we've got this active stretch here, and then we start mobilizing the obliques through the breath work and the apnea, we're going to add an extra little stretch through and lift through our pelvic floor. So the adductor activation is super important. So we're going to do 3 nice slow breaths again and your apnea. And now the legs are lovely and engaged or active. Remember to think about lower ribs, back of your ribs, sternum, and then sternum, back of your ribs are just allowing the slow close of the rib cage. Relaxing your jaw as you exhale and inhale, making sure there's no tension in your face and making sure there's no tension in your eyes. And at the end of the third one, you're going to pause and slowly widen your ribs. You can think about sucking the straw, the blocked nose and the flower, the handles of the bucket widening, the relaxing of the abdominals beforehand. Okay. So we're going to try it with squeezing the ball now, which is another one I do with my clients after, just to get a little bit more activation. And this is to activate this anterior chain. And I do this kind of as a warm-up exercise quite often. So we're going to inhale and just hold the ball in place. And as we exhale, we're going to just gently squeeze it. Then we're going to inhale, open the legs a little bit to just gently hold the ball. And exhale, squeeze. So as we're squeezing, our rib cage is closing. And then at the end of the third one, we're going to keep that light squeeze on the ball as we widen our ribs. So it's inhale, release and widen, exhale and close and squeeze. Inhale, release and widen, exhale, close and squeeze. And after the third one, we're closing our mouth and nose, relaxing our abdominals, because you'll need to, because they'll have a little bit of extra tension in there, and then widen your rib cage. So now we've looked at the legs and we start to engage the legs. We're going to come to sitting for a moment and talk about the arms, because it's easier if I can kind of see you, and it's also kind of almost easier for you to experience sitting to start with. The arms in Hypopressives at the foundational series stay the same in all the poses. So once we've learnt them here, they're going to stay the same except in the quadruped positions, because we won't be able to do these in the quadruped positions. So first of all, let's sit right on our sit bones. So I'd like you to feel your sit bones underneath you and rib cage directly over your pelvis. We're going to talk about this in a bit more detail as well. While we're lying on the floor, our rib cage is an even distance away from our pelvis, because we've found a neutral pelvis and then we placed our rib cage on the floor so that the rib cage is in line ultimately with the pelvis. What we're looking for is to make sure that the distance between the bottom of our rib cage and the top of our pelvis stays the same throughout, all the way around. So we want to make sure that we're not one way this way, or we're not thrusting the ribcage forward, so we've got a bigger distance here and a smaller distance at the front with our lordotic spine. And we've not got that kyphotic spine that makes it smaller at the front and larger at the back. So we're really looking to keep the ribcage an equal distance away all the way around. Okay, so now here, we're not going to worry too much about that because I'm going to talk about arms. Okay, so we want to create an active stretch in the arms. The reason we actively stretch our arms is because we want to get into the big latimus dorsi muscles in our back. Our latimus dorsi muscles feed straight into our glutes feed straight into our levator ani muscle, which is our pelvic floor muscles. So if we have great activation further up the chain, it's going to help lift our pelvic floor using our muscles in a great active resting position. The other thing that we're doing when we work our arms is we start to create space in the joints. And this becomes really important because if everything is crushed in, this is what helps to create that forward head position, which helps to create more weight on the pelvic floor. The other thing we're trying to do here is create space in the nerves. So this underneath here and all through here, we have this amazing nervous system, the brachial complex, a huge system, looks like a big lace necklace when you see it on people, when you see it on a cadaver. On people, you can't really see through people. And we've also got the cervical complex, which is the nerve complex where we get lots of signals that are fed down towards our pelvic floor from the rest of our body. So we want to keep this all nice and moist and movable, and the fascia movable too. So we're going to work the fascia chain, but work the muscles and the nerves at the same time. So we're going to do one arm first. We're going to stretch one arm out towards the side in a kind of downwards V position. Excellent. And I'd like you to really feel like you're creating space across the shoulder girdle. So we're going to pull the shoulder in towards the center of our spine and then slide it out. So we're really creating as much space as we can. Then from here, so if we were in this position, we would be in what's called an external position. So we've externally rotated our arms, and in Hypopressives, this is a Venus position. So if we were to, so we're reaching out through our little finger. If we're to take the other hand and put it out towards the side and not create that active stretch, you can feel the difference in each side of your back muscles, hopefully. We're going to add a little bit more to this though for what we call the Athena arms. So stretching the arm away and creating space across here. We don't want to feel like we're really tensioning the arm. We want to feel like we've got this gentle active stretch all the time. Almost like you've got a little hummingbird constantly pulling you away gently. When we've got something that we're wanting to almost tighten a little bit more or stretch a little bit more, we wind it. So we're going to do the same with this arm. So we're going to start from the distal point, and we'll do it the other way in a moment. So we're going to rotate the wrist first until we can't rotate the wrist anymore. Then we're going to rotate the elbow until we can't rotate the elbow anymore. And then we're going to rotate in the glenohumeral joint, so inside the joint, until our thumb is going towards the floor, no further than thumb to floor. So no hypermobility going all the way around, all the way around, all the way around, because what that creates is a roll in of the shoulder here. And what we're trying to create is just an active stretch through the glenohumeral. So coming to the thumb, maximum distance is thumb to floor. Good. Then from here, so now we've started to twist into our fascia and open up through the joints. Now I want to add a little bit of tensioning on my nerves. So what I'm going to do is extend the wrist. So the fingers are pointing out towards the front. Then we're going to bend the elbow and keep the elbow where it is, as if it's pushing out towards the side, and bring the hand in towards our thigh, keeping that extension in the wrist. Good. And we want to make sure that we haven't rolled the shoulder forward, that it is internally rotated in the joint. Excellent. Then we're going to press lightly into the thigh with the hand, and press with the thigh lightly back into the hand, so you get a little bit more of active engagement through the abdominals as well. Then we're going to take the other hand and just place it on our thigh, and I'd like you just to feel how different that feels on both sides of your body. Can you feel that activation through the back of your body? Perfect. So let's do both hands, and let's go through all 3 basic arm positions. So we're going to stretch both our hands out towards the side in a low V. And this would be the Venus position, which is the easier arm position to find. Then we're going to rotate from the distal point, from the wrist, the elbow, into the glenohumeral joint, and then bend our elbows and place them on the tops of our thighs. Perfect. So we're looking to make sure our clients aren't rolling their shoulders in, that this is a rotation. This is first position. Then we're going to move our arms, still keeping them in this beautiful shape, into our second position, which is directly in front of our body. We want to make sure as we move up to second position that we don't do this, that we still have this beautiful shape in our arms, or the circle. Then what we're going to do for second position is we're going to move our hands up above our head. We want to stop moving our hands at the point where we feel that we want to thrust our rib cage forwards. So everybody is slightly different. Most people stop just in front of their forehead. Other people can get them right up above their heads. So you are going to go to where it feels good for you. Now, once you're here, I'd like you to feel like you've got an elastic band underneath your left buttock, and you're stretching that with your right hand. An elastic band underneath your right buttock that you're stretching with your left hand. So we're reaching from your buttocks and not your shoulder girdle. So we're reaching through the thoracolumbar fascia, a big piece of fascia at the back of our body, and reaching through. So we really want to feel that stretch at this point. Bringing them back down through second, and back to first. Okay, how confident is everybody feeling about finding that when we're lying down? Because suddenly it's all the other way around. So let's come down to lying on the floor into our supine position again. And we're going to add this in. Excellent. Okay, so we've got our neutral pelvis. Rib cage is heavy. Back of your head is heavy on the floor. Legs are hip distance apart, about 45-degree angle in them approximately. We're going to lightly dorsiflex like a dimmer switch coming on. We're going to squish marshmallows underneath our heels and draw our heels back towards our sit bones, keeping our pelvis neutral. We're going to think about holding that little ball between our knees. You could grab one if you want to actually use one just now. Then to find the arm position here, most of my clients find it much easier to find the second to start with. It's much easier to explain it to them actually. So we take our hands out towards the side, hovering a little bit off the floor in a T, with palms facing up towards the ceiling to start with. Pull your shoulder blades together behind you and then allow them to sigh out towards the side, creating that space across the shoulder girdle. Then we're going to rotate our wrist, our elbow, and into the glenohumeral joint until our palms are facing towards the floor. Then we're going to extend our wrists so our fingers are pointing up towards the ceiling, and then we're going to bend at the elbows, bringing our fingertips in towards each other as if we're hugging a beach ball with our palms the wrong way around. So make sure our hands haven't come really close to our chest. Make sure you've got that idea that there's a beach ball in there. Good. Then this is second position. Then from here we're going to bring our hands down, keeping that same beautiful shape down to just above our pelvis. Perfect. Now I'd like you to feel like you've got a hula hoop going all the way around the outside of your arms that you're holding in place. So you're not pushing it hard away, You're just holding it gently there so it's not going to fall. Okay, relax your jaw, relax your eyes. Now don't think about anything else except your rib cage and your breath. 3 nice slow breaths and your apnea. Take your time. Nice and slowly into the ribs, widening the ribs to the sides, behind and the sternum, and exhaling with a relaxed jaw, allowing the ribcage to slowly come back into place. Go very much at your own time, but try and take as long as you can of your exhale, almost twice the amount of time as your inhale. Good. At the end of the third one, you're going to pause and slowly widen your ribcage, thinking sides, back, sternum. When you've done the one with your hands in first position, you're going to take your hands to your second position, directly in front of your chest. So part 2 is directly in front of your chest. Good. Again, think about that hula hoop you're gently holding in place. To have a wee check-in with your feet, your heels, your legs. Think about your sacrum, your head, your eyes, and then do your 3 nice slow breaths. Widening the rib cage and then allowing the rib cage to slide back down slowly. Once you've done your 3 breaths there, and do take your own time of this, I'm just queuing ahead a little for people, is moving your hands nice and slowly up above your head, allowing yourself to keep the back of your rib cage on the floor. If, like me, you can easily get your arms all the way down towards the floor and maintain that position, you're not going there. We want to make sure that you're still self-supporting. So I still want you working. So wherever you bring your arms to is a point just before the point where you feel like you want to arch, unless you've got too much mobility in your shoulders, and you're going to therefore take it to a point just before the floor or where the most comfortable position is for you. So make sure we're not resting them on the floor. 3 back breaths and then your apnea. Good. Nicely done, guys. Any questions, comments, observations? Candida, did you find that easier when you brought the arms in? Because sometimes people find it easier when they start to activate the arms. Yes, no, no.
Yes.
Yes, good.
I do find it easier with the arms, but I have a question about it.
Okay, yes, cool. I'll come, Dorothy, talk to me and then I'll come back to Candida.
With the torsion of the arms, because I am so hypermobile, what are we trying to do? What are we trying to feel when doing it? Because I don't really feel anything unless they're up over here, then I actually feel there's a connection. So can you put words onto that?
Yes. So what we're doing, when we internally rotate into the glenohumeral joint, what we're doing is the muscle that helps that internal rotation is the latimus dorsi. So what we are looking for as we rotate is that activation of the latimus dorsi muscle in this position. So that's one of the things we're trying to activate and feel. The next thing we're trying to activate and feel as we rotate is to create space. So we definitely don't want to be contracting, which is why we start from the distal point, Dorothy, rather than the proximal. If we were to start the rotation from the proximal point, we would end up with real contraction in the shoulder girdle. And you can have a little try of that while you're sitting and feel what that feels like. The next thing we're doing is we're working with the ulnar, medial and radial nerves in our arms. So we're wanting to make sure that there's no, quite often when there's lots of stiffness in the shoulders and the upper body here, we create tightness in the fascia, which will relate to the nerves not sliding and gliding as well as they could throughout the arms and down through the spine. So we're trying to create one, activation of the fascia so that the fluid can flow through, and therefore if the fluid can flow through we can get better slide and glide for our nerves. So there's a lot going on within the arms themselves. The movement of the arms into the different positions, though, is also something. So when we start here, our rib cage is as close to the pelvis as it can get. When we move our arms up, we get a little bit more activation across the pectoral area because of the nature of where our arms are, and we're starting to get a much more engagement into the serratus. And now, as we move our arms up, the serratus is already lifting our rib cage. So our rib cage is already a little bit further away from the pelvis. So that means the intensity of the stretch that we're getting, or the lift that we're getting in our pelvic floor, deepens. Then when we take our hands all the way up, and I think, Dorothy, that's probably why you're feeling it more up here, because of the hypermobility. So you'll feel more of the stretch of the fascia and the connective tissue when it's at its most extreme point almost. So when we come to our third position, when we're in this position here, our serratus is quite engaged already because it's already doing part of the work of lifting our arms up. So most people feel that they almost get less of a feeling of opening and closing their ribs in this position than they do in the other positions, because they're already pretty wide because of that activation of the serratus and the latimus dorsi. So that's what we're trying to do as we move our arms up, is try and get that a little bit more intensity in the lift that we're creating in the pelvic floor. We're also getting a little bit more activation of the chains, of the fascia chains, because the fascia chain now is a long chain that runs all the way through, rather than thinking about more of the shorter chain connections through our arms in the different positions. So there's quite a lot going on there. Does that make sense to you, Dorothy?
Very much. Thank you.
Good, excellent. Candida, how did that feel for you? I'm interested, because sometimes adding the arms and the activation of the serratus helps you open your rib cage.
Yeah, it definitely helped.
Good, excellent.
Yeah. I mean, my arms feel very heavy when they're kind of, well, over my head. Is that normal?
Yeah, most of the time we don't have much call to have our arms up here. You know, we do, most of our life, it doesn't spend much of our time with our arms up here anymore. We don't do monkey bars and things when we're, you know, as you get older. So quite often this is, the arm positions are hard for people. They find them quite difficult. So when you're initially teaching people, lots of rests in between. I get them to shake their arms off and then find the position again and just play with them. We can also add a pulse in, you know, so instead of thinking about holding the hula hoop all the time, look at my brain, the hula hoop all the time, what we can think about is, as we inhale, we can think about pressing into the hula hoop a little, and as we exhale, releasing a little. So it's almost like we get a pulse through our arms that activates the serratus a little bit more. So we can try one of them lying down and see how it feels when you're lying down. So as you inhale, you're thinking about just nudging your elbows a little bit wider, and as you exhale, just releasing a little. And that can take some of that kind of feeling of too much work out of the arms when we're working. So come down and find a position. Let's go for the second position. Well, I'll come back, Rachel, in a moment. So come to the second position. Neutral pelvis, ribcage heavy, back of your head on the floor, and then lightly dorsiflexing the feet, squishing your marshmallows, drawing your heels back towards your sit bones, holding your ball between your knees, coming into that second position, so palms face up from your T, rotate your wrist, your elbow, your shoulder, bend your elbows and bring your fingertips in towards each other. Palms will be facing away. Good. So now feeling that expansion across the shoulder girdle. And just another cue to think about, so there's so much to think about, I'll just add this one in just for a moment. Think about your sacrum drawing one way and your head the other for the length of the spine. So now as we inhale, think about nudging the elbows out towards the side, and as you exhale, releasing them a little with the exhale. It's my phone. It sounds like a train because my children trained it to that. So it's inhale, press out a little, exhale, release. I just check it's not an emergency. Good. Yeah, Sharon, when you come into it, to find it easier, if you start with your palms up and then rotate your wrists, your elbow and your shoulders so your palms face down, and then extend your wrists. And once you've extended your wrist, then it becomes quite easy to find. Yeah. So yeah, I get a lot of clients who end up like this, you know, in this position, like ballerina hands. But yeah, if you think about the extension before you bend, it's much easier to find. Okay. So, that's a nice way just to, so it's not that active stretch all the time, which can be a bit much for people's bodies if they're not, you know, not used to it. And you can bring it in. But you actually start to find that people start to pulse their bodies while they breathe when they get really in the zone with breathing. So it's quite nice to just add that in as a thing they can do. Rachel, did you have a question?
Yeah, just, well, two things really. One, really nerve pain. So coming
talk about that.
Stretch is very, very, well, me personally, it's really, really nervy, quite painful. But also shoulder, so many of my clients have shoulder issues. So, you know, what do you do?
So there's two questions there. Both, yeah. So this is a real nerve activation, this position here. These positions here are real nerve activations. They can become more nervy if you have your fingers open, less nervy if you close them, and we can do a switching off of the nerves almost if we make fists. So my clients that find this difficult as a nerve position first, what we do is we take our hands into a light fist, so definitely not a hard fist, and I'll explain why in a minute. So you've got a light fist, you twist your wrists, your elbows, your shoulders, and you bring your hands in. And this way we take the nerve extension out of it loads. I think you're rotating too much, Rachel, so come back out again. I think you're rotating too much through your shoulders. So you want to just come to a point that feels comfortable. So the maximum is thumbs to the floor. So you come to where it's comfortable.
I get the nerve stretch just taking my arms out.
It's all right. We're good. Yeah, I know. I've got another option for you, so don't worry. So if you're finding that too much, this internal rotation, then I keep my clients that are finding that too much into external rotation. So they don't come into the internal rotation immediately. What we do is we start them with their hands out towards the side, palms face forwards, in external rotation. So we're starting to feel that extension through the nerves, and you might feel it. If you're somebody who feels your nerves loads, if there's quite a lot of tension in them, even just having your hands out towards the side like this can feel quite nervy. So even in this position, you can make a light fist to take the nerviness out of it. And then as we get used to this active stretching of the nerves through the body, then we can start to bring in the internal rotation. So we have the other hand position. So this is Athena arms, 1, 2, 3. We also have Venus arms, which are out towards the side. And again, we want to make sure, and this is really important for hypermobility, we want to make sure that the elbows never fully extend, so they're gently soft. We want to make sure that if you're looking straight ahead, your fingers, you can see them in your peripheral vision. Always see them in your peripheral vision. And if this is too nervy, then you can make a gentle fist with your hands. And this is where I start people who are struggling with the nerves in this position. And then from here, we can take them up to our second position, which is our T. And then, depending on how they're feeling, I take them up to their third position. But we can move between first and second, or just keep them in first position for most of the work. So you don't have to take it all the way up here. This is where we're going to get the most lift. But to start with, we want to always make sure we're working with comfort. The minute we come out of comfort, your body starts screaming at your nervous system. And this is really important. And this is the difference between Wim Hof and what we do. One of the differences is that Wim Hof, when you do the Wim Hof breathing, it's to elicit a sympathetic nervous system response. So that when your body recognizes stress again, it knows how to cope with it. What's one of the major tenets is to kind of almost produce inflammation so your body knows how to deal with inflammation. What we're doing is we're trying to create a harmony in our nervous system. So we want to make sure that the sympathetic nervous system and the parasympathetic nervous system are working in harmony. So we're in what's called the ventral vagal system. And we want to be in this ventral vagal system where we can take our body into excitement or fight or flight or daydreaming or freeze when it needs to, but it can come in and out nice and easily. The reason this is so important for your pelvic floor is your pelvic floor needs a balance. Your bladder especially. Your bladder has two processes it does. It has a filling phase and a voiding phase. But the urethra does almost the opposite. So when you're going through your filling phase, that's your parasympathetic nervous system is operating. But during that filling phase, your urethra needs to be closed. Otherwise you leak everywhere. And so during that filling phase, the urethra is in sympathetic nervous system. because what it's doing is squeezing shut while this is allowing itself to open. Then, as the detrusor muscle that surrounds the bladder squeezes in sympathetic nervous system, the urethra has to be in parasympathetic to release. So if our nervous system is caught in fight or flight, then we're going to have dysfunction in our bladder and our pelvic floor. So what we're really trying to do with our clients is bring them into a state of pelvic harmony. And we do this through really lovely, soft, relaxed breathing, making sure the postures are comfortable for them and that they're not pushing themselves too hard. So we're really listening to their bodies. So for a few of my clients, they really do just stay here in this position with their arms. Nice, relaxed through the elbows and just feeling that space across the shoulder girdle. Nice, relaxed here. And the reason we've got relaxed fists is this. I'm going to get you to do it. So I'd like you to, first of all, think about your diaphragm and really just feel how your diaphragm feels just now, and this whole area in the center of your body. And then I'd like you to make a really hard fist, really hard, really scrunch your fist together and feel what that does to your diaphragm. Can you feel that tensioning in the diaphragm? So if that's tensioning, your pelvic floor is also tensioning. So we want to make sure that we've got nice relaxed hands. It's really, there's a diaphragm in here and we need to make sure it stays relaxed. Okay, so now we've gone on a history of the pelvic floor. We talk a little bit more about the anal sphincter in part 2 of the series because it's got a different connotation to muscles. So we are going to come, I've got so much to tell you. We're going to come to standing and we're going to have a look at this all standing because some people really find that they get much more from it standing. And we've got a range of poses. The reason we have a range of poses is 1, different stretches for the fascia and muscle chains. 2, different orientation of the diaphragm. So when we're lying supine, we're in a neutral position. When we're standing, sitting, or the other pose that we're not doing today, which we'll do in the part 2, aura position, we are in an upright position. And in hypopressives, we call that a loaded position. The reason we call it a loaded position, I'll put this microphone close to my face. The reason we call it a loaded position is because our diaphragm is not just working as a breathing muscle, it is also working as a postural muscle. So it is loaded. Then we have positions that are called unloaded positions that we'll do next, which are things like hip hinge and quadruped positions, where our diaphragm is being helped by gravity rather than having to work against gravity. And they're called unloaded poses. So let's come to standing. Excited, yeah? So we're going to move up our food chain. Before we get started though, we're going to warm our feet up a little bit more. So I'd like you to spread your toes nice and wide, soft knees, and I'd like you to lift both your big toes at the same time. Now, when you do this, I'd like you to check where your toes are going. Are your toes wanting to wander across into the foot they belong to? Or can you lift them straight up and out towards each other? We want them straight up and out towards each other, not towards the foot that they come from. And you can use your eyes for this too. Then we're going to lift all our toes up off the floor and place just our big toes down. Again, we want them to be pressing into the floor and pulling towards each other and away from your foot and not in towards the foot that they come from. If they wander across the foot that they belong to, there's a good chance that it's going to create space and your body will produce more bone and you'll have lovely bunions to look forward to later. So this is really important that we look after this big toe. Okay, it's also for balance and other things too, not just bunions. So then lifting all our toes up, we're going to put just our little toes down. Again, keeping our knees soft. If you've had to roll your foot over to get your little toe down, keep your little toe down and roll your foot back over. So you get that stretch across the toe box at the front. Then we're going to lift all our toes up and we're going to place our big toe down and our little toe down, trying to keep the middle 3 up. So this is a neural pathways thing. The more active and mobile our feet are, the better your balance is going to be, and also the better the innervation or movement of your pelvic floor. So it's really, you can work on this in the toilet, when you're sitting on the toilet, with your feet up on like toilet rolls and all the things you're supposed to do. So, okay, so from here now, we're going to do a little Mexican wave. So we're going to lift both our big toes up, and then we're going to try and slowly pick each individual toe up until we get to our little toe. And then we're going to go back from our little toe to our big toe. Good. I still use my fingers when I do that. I automatically use my fingers when I do that one. And then before we go any further, we're going to stretch the back of our foot off because we've been doing all that dorsiflexion already. So we're going to take the back of our foot, the dorsal part, and place it on the floor. And while we do this, we're just going to take like one nice big lateral breath and swap to the other side. And just feel that nice stretch up that part of your body. Opening this part of your foot helps to open into your hips and hip flexor. So if you're somebody that's predominantly tight in the hip flexors, this is a great stretch to do to connect in with that. Okay. So again, back of your foot, dorsal part on the floor, and try and keep your heel so it's in line with the rest of your legs, so it's not flopping off to the side, the way mine used to prefer to do. Okay. Right, let's start the whole pose. So we're going to start from the bottom. So I always start from the feet. So we start with our feet and we want them hip distance apart. We want them pointing straight ahead, and we're going to try it the other ways just so you can feel what it does to your body. So I'd like you to bring it so the heels are pointing in towards each other and your feet are pointing out towards the side, the way my husband walks. And I'd like you to feel how that feels in your body. Can you feel what's happening with your posture and your glutes? So what's happening in your pelvic floor is this. As you bring your heels together, the back of your pelvic floor, your sit bones are drawing in. So if you think about your pelvic floor like a triangle, the back portion of your pelvic floor is contracting while the front part is being pushed out. And initially, we want to work them in a symmetrical way, especially. So we had a feel of what that did to our glutes as well. It started to tuck our tailbone under and all sorts. Now I'd like you to do toes together and feel what that does to your posture. Now what that's doing is pulling the front of our pelvic floor together and pushing the back apart. You might feel quite lordotic and a little bit like things are like not right in your pelvis. And that would be true. So we're going to come to feet hip distance apart. And we want toes and feet pointing straight ahead. We want to have our knees nice and soft. So we're not bending our knees. What we're essentially doing is releasing our quadriceps so that we can release the knees so they're soft. This is especially important with my hypermobile ladies. It's important with everybody, but hypermobile especially because they tend to hang off their knees and their quads. So we want to make sure that they're not doing that. Because it definitely throws you, the minute you do tight knees, it throws you into this banana structure. You can try it on your own bodies and just really tighten your knees and feel what that does to your body so you can feel how they feel all the time. This starts to feel normal. And it's because their bodies if you're hypermobile, your body is trying to find ways to find stability. So it does all these sorts of neat tricks for you, which aren't always good for you. So nice soft knees. And then we're going to find our neutral pelvis. I'm guessing you all know how to find a neutral pelvis and describe this to people. I have a nice cue I use with all my ladies now, where I get them to imagine they've got a torch shining out of their vagina, if they're men, out of their perineum, and that torch is shining straight down towards the floor. If the torch is shining behind them, they're anteriorly tilting. If the torch is shining out in front, they're posteriorly tilting, and we want it straight down towards the floor. And it tends to work. I don't know why. So then from here, we want to have our rib cage directly over our pelvis. So I'd like you to hold your rib cage for a minute, and I'd like you to pretend that your rib cage is a bell. So what we're going to do first of all is we're going to ring our bell forwards. So we go into what a lot of women are in, which is this real rib flare and lordotic spine. And I'd like you to take a deep breath in and just feel where you can feel the breath. Okay, you can feel it really at the front of your body, yeah? Now I'd like you to take your rib cage and I'd like you to create more of a kyphotic spine with it by ringing your bell backwards and take a breath. Can you feel how you can breathe into the back of your body but not the front? Now I'd like you to take your rib cage and place it right in the center, and now take a breath. And can you feel how you can access all the areas of your rib cage? That's where we want it. And we want to have it an even distance away from our pelvis all the way around. Okay, next, shoulders up towards your ears, and then drop them down gently. Chin horizontal to the floor, eyes gazing straight ahead. And we want to think about listening to a conversation behind us. You're in a busy restaurant, there's a juicy conversation happening behind you, and you're just trying to gently listen into that conversation. Next, I'd like you to feel like your heels are growing roots into the floor, your toes are relaxed on the floor, and your head is growing away towards the ceiling. So you've got long length in the spine. Then we're going to shift our weight forward onto the balls of our feet, keeping our heels connected into the floor. So nothing else has changed about my posture. I've just shifted forward a tiny bit. And again, this is recreating that dorsiflexion we had on the floor. So it's creating that active stretch through that posterior fascial chain. Now, not doing anything else now, just hanging here nice and relaxed with all this activation going on. We're going to do 3 nice slow breaths and an apnea. You can have your hands around your rib cage if you want, or hands just by your side. Nice deep slow breaths, lower ribs, back of your ribs, sternum. And as you exhale, just keeping that little bit of extra height as you exhale. Good. And after the third one, you're going to pause and slowly widen your ribs. Good. Then from there, we're going to take our hands out towards the side, palms face forwards. We want to make sure we can see our fingertips in our peripheral vision. We want to reach out through our little finger and have that wide open shoulder blades behind us. So you can pull your shoulders together and then allow them side towards the side so you can really feel it. Now, if you want to stay here, you can stay here. You can make a little light fist with your hands. Or we can go for the full internal rotation where we're going to twist our wrist, our elbow and our shoulder and bring our hands in front of us. Good. Nice. So either works because I use both all the time interchangeably. So here we want to make sure our fingertips aren't too close together, because if we bring them too close together, you'll start to feel a tightening across the top of your chest. So we want to have our fingertips so they're about, everybody's slightly different. We want to have them so you can feel that you've got this wideness across the pectoral area and wideness across the back of your chest without any tension, but everybody is slightly different. I'd like you to feel like you're holding that little hula hoop in place again. You're still shifted forward, your knees are still soft, and then 3 breaths here and your apnea. Take your time, nice and slowly. Each time you exhale, leaving that little bit of height in your sternum. Really feeling the breath into the back of your body here. And at the end of the third one, you're going to close your mouth and nose and use that pause. And then slowly widen your ribs. You might want to use your bucket handles. You might want to use your sniffing the flower. And then from here, you're going to take your hands out to a T position. Palms facing forward, still nice and wide across the shoulder girdle, making sure you can see your fingers in your peripheral vision and your elbows are nice and soft. Reach out through your little finger. Good. Make sure your weight is still forward, your knees are still soft, your sacrum is growing towards the floor, your head towards the ceiling, your heels growing roots. Relax your face, relax your eyes, gaze straight ahead. 3 nice slow breaths and an apnea here. Take your time. Good. Once you finish that one, give these arms a shake off. Good. These look nice. We're going to go for the third position now, and we're going to use external rotation, so we really feel the stretch that we're looking for. So we're looking for our through activation through the fascia chains that go up through the back of your body. We've got an amazing piece of fascia here at the back called the thoracolumbar fascia. And it's a massive crosshatch of fascia, and it's like a loading point for our body. And it's also one of the reasons why people get low back pain is because, remember, I talked about maybe I talked about it yesterday, but all the pain receptors are in our fascia. So quite often this is where the pain is. We want to stretch right through it. And most people, when we go to reach things, we use our shoulders and not our backs. So we don't get much work into our backs in general daily life. So what we're going to do is come back to our feet hip distance apart, knees soft, neutral pelvis, rib cage stacked, chin horizontal to the floor, eyes gazing straight ahead, Nice relaxed jaw. If you smile during the apnea, by the way, you get a little bit of an extra lift because you're drawing the epiglottis up as it's being pulled down, so you get this extra kind of lift. So then from here, we're going to take our hands up to our high V. In our high V, I'd like you to think that you're stretching from the left heel and you're pulling a string all the way up through the back of your body to your right hand, and from the right foot all the way up to the left one. So you can really feel a stretch through the thoracolumbar fascia. Good. So now we're reaching from our back muscles, not our shoulders. Make sure the balance point is forward. Relax your face. 3 breaths here. And at the end of the third one, you're going to pause and slowly widen your ribs. Try smiling on the apnea. Good. I find the smiling during the apnea thing because I was reading up for my singers about all the epiglottis and everything. I got this amazing book on the voice, anatomy and the anatomy of the voice, and she was talking in that. I think she's on most Pilates reading lists. Kelly's Germain. She's got lovely stuff, lovely pictures and things, but she does one on the whole neck area, and she was talking about how as you smile, you lift the epiglottis, and so you do get an extra lift through the body when you activate the epiglottis during the apnea. But yeah, that was a byproduct of other learning. So how did the standing pose feel for you all? Good. Okay, any comments or anything you want to share or anything you'd like me to go over with that just now? I'm going to briefly go back over all of it anyway.
Quick question.
Yes.
When we were on the back, you said in the break after 3 breaths, release your stomach muscles. When I get to standing, my stomach muscles do all kinds of things. Should I completely, after the 3 breaths, let them go and just let them be still, or in standing, they want to help?
Yes. So I always say when you come to standing and things, just release them a little bit. So 5%, 10%. They're doing so many other things to help us in the standing pose. So just if you feel that you've got extra tension, or you feel that you could get more of an opening through a little bit of a release, just release a tiny bit and then open your rib cage. We really, when we're in supine, because we're not in a postural pose so much, we're in a much more neutral body pose, we're not asking the rest of the muscles to do work, but we are here, and we want to make sure the back of our body and the front of our body works in unison with each other. So we don't want to let go completely. And yes, thank you, Dorothy, because you keep bringing me back to the points that I'm supposed to have said. So that's great. So thank you. Keep coming with it. So yeah, when we're standing, if you're doing that release of the abdominals, just releasing it about 5%, 10% is all we need.
Thanks.
Okay. That's okay.
I've got a question.
Wendy, yes.
How long could we hold the apnea for? If you can,
Good.
If you can comfortably hold it, should you go as long as you can, or?
Yeah, so that what we're looking for is between 10 and 12 seconds up to 15-second holds, and no longer than that, because we want to get flow going in the body. And we're going to talk a little bit about breath now at this stage before we move into the next posture as well. So because I want you to try a few things out while we're here. Because it's
I was intrigued about this reference to putting the weight a little bit more forward on the balls of your feet, so your heels are still connected, which is not what we say in Pilates. The say in Pilates is equally weighted between the ball of the feet and the heel.
It's less that we're shifting the weight and more they're shifting the balance point. So it's, to be honest, when we shift forward, we still kind of want to have even weight between the balls of the feet and the heels, but we want to have the balance point forward. So it's almost like the heels are working slightly harder because the weight is at the front. So in order to keep them weighted equally still, our heels are having to work hard, and that harder kind of push into the ground with the heels is what's helping to actively stretch the posterior chain.
I see.
Again, thanks for that question, Deborah, because oftentimes I forget to mention that because there's so many other cues in here. And what tends to happen sometimes with clients is I say, balance point forward, and then they start to lift their heels off the floor. And actually what we want is more activation in the heels as we start that lean forwards. So yes, thanks again. I should have like a checklist on the wall that I tick as I go, you know. We always get there in the end, which is good. Okay, so a little bit about breathing. We're going to do the standing because it's nice to do the standing rather than lying down. And before we move into a little bit about breathing, just the last thing about arms as we move through. Your arms, you can choose where you want to put them for your clients. We've kind of gone through it, but we have the 3 arm positions. There's Venus arms and Athena arms, which is internal rotation. You don't have to do all Athena arms. You could do Athena here, Venus here, Athena here, when you're taking people through their 3 breath cycles. So you can play with the arm positions. And if you're coming to do part 2, there are many more that you can then play with after that. But to start with, experiment with using these in different ways and what feels good for your body. So breath work. So we're going to come to standing again. We're not going to worry too much about the arms just now, but we are going to come into that little forward lean position so we can really feel that activation through the posterior chain. I ask my clients to breathe for exhale for twice the amount of time they inhale for. And we're going to do a little practice of the different time frames. The more I learn about breath, the more I know that on an individual basis, if I'm seeing somebody one-to-one, I'm trying to find their own natural cadence. And if they breathe really fast, I will give them a count to start with to help slow them down. But eventually I want them to find their own natural breath cycle. But I want them to exhale for longer than they inhale for. So if they inhale for 6, I want them to exhale for 8 or 10. If they inhale for 4, I want them to do 8 or 6, you know, so I always want a little bit longer. But when I'm teaching them as a cadence, I teach them it as twice the amount of time for the exhale. And the reason for this is it's the CO2 leaving the body that does a dance with the hemoglobin that helps to release the ATP energy cells that we need for more energy. It is the CO2 leaving your body that cleanses your respiratory system. It is the CO2 that improves your CO2 tolerance, which improves your sports stamina, which improves your recovery times. So we need to get comfortable with our CO2. The longer we can exhale for and the more comfortable we are with our CO2, the longer we're going to be able to hold our apnea for as well. So the more benefits we're going to get. So there's huge benefits to a long, slow exhale. So we're going to do a couple of tries of different ones, just for fun as well, just so you can feel them in your body. The faster one is the one that's taught by UK Hypopressives as a standard. So it's a 2-4 breath. So we're going to do that one first, and then we're going to do 3, 6, 4, 8. We're just going to do 1 breath cycle in each. So 3 breaths and then an apnea. So finding your nice alignment, making sure your ribcage is lined up with your pelvis, your head's lined up with everything else. Hands can be nice and relaxed, or if you want to, you can bring them into one of the arm postures. So let's do the first one. I'm going to count units 2 and 4. So ready to inhale. In, 2, out, 3, 2, 1. In, 2, out, 3, 2, 1. In, 2, out, 3, 2, 1. Close your mouth and nose. Pause. Widen your ribs. Widen them. Feel how wide you can get them. Sides, back, sternum. And when you need to inhale, just inhale. Okay. Well done, guys. So think about how that made your body feel. And now we're going to do 3 and 6. So when you're ready, find your positions. Let's go. Ready to inhale. In, 2, 3, out. 5, 4, 3, 2, 1. In, 2, 3, out. 5, 4, 3, 2, 1. In, 2, 3, out. 5, 4, 3, 2, 1. Close your mouth and nose. Pause. Widen your ribs. Take your time widening to the sides, behind that sternum. Feel your heels on the floor, your head to the ceiling, your shoulders nice and wide. And when you need to inhale, inhale. Think how that made you feel in your nervous system and your body. And now we're going to do 4 and 8. So ground yourself, ready to inhale. In, 2, 3, 4, out. 7, 6, 5, 4, 3, 2, 1. In, 2, 3, 4, out. 7, 6, 5, 4, 3, 2, 1. In, 2, 3, 4. Out. 7, 6, 5, 4, 3, 2, 1. Close your mouth and nose. Pause. Widen your ribs. Really focus on that feeling of widening to the sides, behind, sternum. Smile if you want. And when you need to inhale, inhale here and exhale, release. Okay, for most people, those 3 are manageable. Let me know how it felt for your 2 and 4 and which one feels best for you. How did you all feel? What did 2 and 4 make you feel like?
It's too fast. Felt a bit,
Fast.
yeah, a bit anxious.
Yes.
Very much so.
The majority of people find 2 and 4 far too fast, and it makes you feel really anxious, which is the opposite, when we've talked about the pelvic floor in your body, the opposite from how we want to feel. How did you feel at 3 and 6? Good? Some people good. And 4 and 8?
Better.
The best, yeah.
So quite a lot of people actually find 4 and 6 the easiest one to do. But I'm kind of proving a point with the CO2 here and really wanting you to work with your CO2. So that's why it's the 4 and 8. But quite a lot of people, when I give them their own natural cadence time and we count it, it's a 4 and 6 for the majority of people. So you might find you're happier there as well. But when I'm teaching a general class, I do mix it, but I generally stick to a 3 and 6 count for a general class. And I add in breath challenges where we do bits of other ones as well. Okay, so we are, posture patterns. So the next thing, we're going to come back up to standing and think about specific posture patterns that I see with people with pelvic floor dysfunction. And then we're going to go into our hip hinge position and move down towards the floor for our next ones. So posture patterns. When people have a pelvic floor dysfunction and prolapse, their body will do beautiful things, which it thinks are beautiful things, to help them out. The most obvious one, and the one that happens the most, is butt clenching. So what starts to happen with the women here is that their bottoms, their glutes, try to do the work that everything above their pelvic floor should be doing. So their bottoms start to disappear and they start to get this kind of almost posterior tilt. And this is really, really common. So the glutes are overworking because they're on all the time. And the pelvic floor is scrunched up in this position here. And so for these ladies, especially when we come into our hip hinge position, it can be a struggle to get them to let go. So when you come to the standing position and you're teaching the standing position, once you get them into neutral, and I do this just as standard, I get them to release their glutes. I want spongy glutes in standing initially. You know, before we do the lean forward, where everything starts to activate a bit more, when we're standing upright, release the glutes. And this can be really terribly difficult for people to start with, and it has to be cued often. So I get them to think every time they switch on the kettle or every time they go to open the door, are my glutes tight? Because this tension just creeps back in all the time because it's been your pelvic floor's go-to for so long. The other one, that's a massive one, is actually starting to try and lift the pelvic floor from above. So what your body does is it does this tightening at the lower ribs here. So what happens here is it starts to create a kyphotic spine. So they've got this real pulling in here. So there's a real tension across here. And when you try and teach women like this, the apnea breath for the first time, it's really difficult because there's so much tension in here. So I do a lot of release work with the rib cage and with breath before I even go near the apnea. I had a recent client in Australia who's she had had 5 children and had breastfed them all and had had pelvic floor dysfunction since the first one, and her spine had become so kyphotic that the abdominals were no longer engaging at all. Everything was tight here. Her spine was really becoming humped, and we spent the first 3 sessions unraveling her just using breath work to try and get her. And she found it remarkable how much better her pelvic floor felt once she started to actually have this straight activation through the anterior chain instead of this kind of stop here. So the activation stops here and there's too much going on in the back. So these are the main ones. We also get both of them together. So we have glute clenching and lower rib clenching. And this can become really, really bad for people. So when you first see people, making sure that they can release their rib cage, and you do that through breath, lying on the floor or sitting or standing, and just doing the work that we've already done today. And with the glute clenching, it's a constant reminder. But it really works when we come into hip hinge to really hone that home to them, how much they're glute clenching, both in hip hinge and in quadruped positions. Any questions about that?
I have.
Yes, Rachel.
The relationship between shoulders. And so I often see, as a Pilates teacher, you know, when you're trying to get that gentle core activation, and women particularly that really struggle with it, and that whole thoracic sling and that. Can you explain that? Can you talk a little about that? Because
when they're up here constantly.
Yeah, or they're trying to activate, but they can't. So they can't do one without the other. The massive link between, you know, it's all to do with the breath, I know, and that release, but there's,
for them,
it's not happening.
They're the ones that do the upper chest breathing.
Yes.
So they don't breathe into their belly. So everything has become so tight up here that anytime you ask them to lengthen or do anything, everything comes from their shoulders, because this is all they know now. So for this, to release this, instead of talking to them about the shoulders, talk to them about the lower ribs and get them to mobilize here, and this will come. I tend not to cue the shoulders too much because they've become... They're almost so activated that we need to find a way to deregulate them back down again. And so for them, I get them to really focus on the lower ribs when they're breathing.
It is that always talking to them about relax your shoulders, release your shoulders. But it's that, you know, and I don't know how other people, we're all Pilates teachers here, I think, and that gentle, deep abdominal engagement, or that waistcoaty feeling, or whatever it is you're using to help people stabilize when they're moving with their Pilates. And these are the women that, as soon as you cue anything to do with that, it's just that, I guess that's, again,
so
back to the ribs.
Back to the ribs and back to the jaw, Rachel. So if they're like this, their jaw is going to be tight as hell. Their scalenes are going to be tight as hell. So it's getting them to move their neck about. And quite often when I get people who are like that and they're going into the apnea, you can see them when they start to do the apnea, they start to try and lift from their scalenes. So they'll default back to that. So instead of widening their rib cage, you'll see this happening. And everything gets incredibly tight up here. These bulge like mad, you know, and at that point I get them to relax their neck, move their neck about, and then I if I'm in a room with them, I touch them. I touch the back of their rib cage and get them to bring it down and lower everything down more. Tricks, it's all tricky finding out how to unravel people, but generally with most people, it's either dropping the tongue, moving the neck, relaxing the jaw, bringing the breath back down to here, and get them to really focus here instead of up here. And I also found that when you bring the arms in and you get them to stretch out towards the side in a downwards V, this helps them because they can't actually do that with their shoulders. So bringing the arms in quite soon with them is also good. I don't know if anybody else has got any tricks that they use that they want to share.
Is it usual to need to pee more when you're doing this? Or I feel like keep feeling like I need to go and pee.
Yes, and there's a reason for that. So when we're doing this, your bladder is being moved about. So especially if you've got some sort of dysfunction happening already. So your bladder hates to be irritated. So irritation can come from inside and it can come from outside. So a lot of people with pelvic floor dysfunction stop drinking water because they're so worried about peeing. And then what happens is the fluid inside becomes concentrated and they need to pee more often. So it becomes a self-prophetizing circle where the less they drink, the more they need to pee. The less they drink, the more they need to pee, until it's just awful, until it becomes burning and horrible because it's so concentrated. And so they need to do bladder training, and there's tons of stuff on the internet about bladder training, and I really encourage you to talk to all your clients about it, because a lot of them will not be drinking if they've got pelvic floor dysfunction. The other one is from the external movement. So your bladder should sit nicely on your pubic symphysis at the front. It's like literally on your pubic symphysis. And if you need a pee, you can actually feel it. If it's full, you can palpate it and touch it just above your pubic symphysis. Your uterus is just above that, and your rectum is just above that, because our pelvis is, you know, kind of like that. It's not, you know, we anterior tilt, but it is always like a little bit that way. So they're kind of lying on top of each other a little bit, or supporting each other a little bit. So for example, I say to a lot of my clients, are like, I can totally sit down for ages and drink loads of gin and tonics, and then the minute I stand up, I totally need to pee. And the reason is because of the pelvic floor dysfunction, when they've sat down, quite often they've rolled into the back of their sacrum. And so their bladder has also rolled away from where it should be sitting. And so when they come to stand up and they straighten up, their bladder rolls back again. And that irritation is enough to send them running to the toilet. And as we do hypopressives and everything gets better resting tone, then that happens less and less. However, when we first start doing the hypopressives and we start drawing the bladder up using the parietal fascia and getting that traction in, we're mobilizing the bladder. And oftentimes people will need to pee more than they did before in the initial learning stages of hypopressives. And that's why. Yeah. And I tell them not to sit with their sacrum tucked under when they're out drinking, and they might go to the toilet in time. So that's the other thing. But that's for another, yeah. And the other one, to make sure clients aren't doing, another thing maybe to talk to them about, is to make sure that when they're on the toilet, there's two things before we move on, actually, because these are all really important. This chair's too big. So when they're on the toilet, they don't want to be in a position where their knees are lower than their hips. They want to be in a position where their knees are slightly higher than their hips or higher than their hips. They want to sit upright. And they definitely don't, if they really need to go to the toilet all the time, one of the things they definitely don't need to do is lean forward and squeeze with their abdominals. Because what that does is it teaches their detrusor muscle that's supposed to squeeze that it doesn't need to do its job anymore. That it's okay because you'll use your abdominal muscles instead. And these clients are the ones that pee when they leak urine when they're walking, they leak urine when they're walking upstairs. And the reason that happens is every time they engage their abdominals, their body goes, she needs to pee. And it does that for you. So the most dramatic results with some of my clients who have this issue when they're walking and going upstairs has been getting them to sit upright on the toilet, relax, take their time, wait for their pee to stop, allow their pelvic floor to do what it needs to do, and then they get up and walk away. And it takes time to retrain your detrusor muscle so it's working. So they need to be patient with it. But it doesn't take so much time, you know, it takes a couple of weeks. And then they should be back with their detrusor muscle working. But yeah, we don't want to, but a lot of people are taught double voiding by their gynecologists, which is where they're supposed to lean forward and keep their abdominals relaxed. So they do get that little bit of pressure to help with the last of the urine coming out, if they're somebody who retains urine or has lots of issues with it. The difference is that their gynecologist says, relax your abdominals. And what people do is they squeeze to try and get the last of their pee out. So they say to me, my gynecologist told me to do it like this. And I'm like, no, your gynecologist didn't tell you to do it like this. That might have been what you heard, but they told you to relax your abdominal muscles. And the reason for that is so that your detrusor muscle doesn't stop working. Yeah, so there we, a little bit of a trip about town for that one. So let's come in now. We thought about glutes and everything. Let's come in to the hip hinge position. Does anybody need to go for a pee actually? Because I'll just keep going. Yeah, should we have a short break before we come into the rest? Let's do that. Let's take 10 minutes now for peeing for everybody. Let's do that. And then I'll be checking my dog and the baby bird outside my door. And we will come back in 10. Okay. Hello. As people come back, the baby bird is still alive, which is good. Any questions, Nikki? Deborah? Okay.
I must say my shoulders feel great after all.
So twisting. It becomes even more twisty in the next one. And in level 3, it becomes like flamenco dancing. So there's lots of like rotation and flexion and extension of the wrists as we move up. So, as people start to come back, we're going to be looking at the hip hinge position. And how poorly it can be done and how great it can be done as well. And you're probably all very good at doing hip hinge positions. So. But I'll show you what to watch for in clients when they come into this position as well, and the cues that I use, which sometimes help as well. I'll just wait till everybody's back. Okay. Any questions while we're waiting? I'm always open for questions, you know.
Yeah, I've got one.
Okay, Nikki.
I think I read somewhere that hypopressives can help tendinopathies.
Can help what?
Tendinopathies, like tendon.
I think it's because of the active stretch through the fascia chain. So it's what we're doing is quite often imbalance, things that happen to our body, like tension in muscles and tendons and stuff that's going on, can be because those parts of your body are overworking to compensate for another part of your body. And because we treat initially, especially at the very beginning, we treat everything in a very symmetrical way. So we're encouraging both parts of our body to work at the same amount, or put the same amount of work in. So it tends to sort out imbalances. Quite often people will have posture patterns that they adopt all the way through the day, where they're like, maybe like this is mine that I'm training myself out of slowly. But they'll have ones that they recruit all the time, and they might even, when they go to an exercise class, still recruit those. You know, if they go to like a body pump class and things, where the instructor's not there watching you in the same way a Pilates instructor would, or I would, or and they'll use those ones, and then that's where they create pain and issues with their bodies, because they go into that and they go in with their dysfunction and carry on using it, and then their body compensates and it hurts itself. So I think that's why this works so well for actually sorting out issues that come from poor postural, because we're really hyper focusing on keeping everything working in a unified way. I hope that makes sense. Yeah. I've gone to a couple of body pump classes and things just to see how they're taught, and it's pretty scary, because I'm a kettlebell instructor too. So, I go and I kind of like, busman's holiday sometimes, and it's just like I'm looking at women do the most awful things for their bodies, and have to be silent. I know up here anyway, they teach from the front of the class, and they don't go around and watch their grip or how they're lifting their weights, or and they get them to do things. They had one class I went to where they got them to put the metal plate on their head and then do a sit up, and I was just like, oh God, that's just like, I refused, obviously, but yeah, it's quite scary, the kind of advice people get given out there in the real world, in the wild. So we are going to look at hip hinge. So our hip hinge position, what we're going to be doing is, first of all, finding our beautiful alignment. So our feet hip distance apart, knees soft, feet pointing straight ahead, neutral pelvis, rib cage stacked on top of our pelvis, shoulders super relaxed, pull them up towards our ears and just drop them down. Then listen to our conversation behind us. And then all we're going to do is hinge at the hips. So all we're doing, this is the most difficult thing for some people to do, for everybody. So all we're doing is changing the orientation of our body. And so that means that our neutral spine will still stay neutral. Our knees will still stay soft, they won't bend. And all we're doing, so what we're essentially doing is taking that posterior chain I've talked about, that's like a band that goes all the way up through the back of our body. It's muscles and fascia and lots of different things. And we're just giving it a little bit more of an extra stretch. Our arms initially can be like, you know, kind of Alexander technique style, nice and relaxed through the shoulder girdle and everything. And then we're going to turn them around and place them on the tops of our thighs. Okay. If this is too much, this internal rotation is too much for your nerves, you can have them so the palms, the fingers are facing down towards the bottom of the legs, which takes some of the internal rotation out. But the full pose is internal rotation in here. Keeping the shoulders nice and wide across here and making sure we're not curling them in. Okay, so once you've found that position, I'm going to go through what goes wrong with this. So make sure we're not bending the knees, because that takes this, that diminishes the stretch that we're getting through the posterior chain. So the knees are staying, my knees don't change. They're exactly the same. Nothing changes. Just the orientation of my body. We're going to talk about glutes and everything in a minute. I want you to try it first, and then we're going to go back through it. I can see some glute clenching. So we're shifting our weight forward onto the balls of our feet, feeling our heels are pushing into the floor to make sure that we're even. And then we're going to make sure that our neck is not contracted, that our head stays in the same position it was in. And we're going to do 3 breaths and an apnea here. And then we're going to talk through what looks right and what doesn't look right, but only once you've tried it. And I'm going to look at people's bums. 3 breaths here. Take your time. So Candida, straighten your legs a little bit. Yep, so the hip hinge isn't a squat. There we go, better, good. Okay, so once you've tried that, 3 breaths in the apnea, we're going to think about all the things that can go terribly wrong with this pose. And we're going to think about a really good cue that can help with them. So the first one is, if we're holding on to tight glutes for whatever reason, as we come into the hip hinge position, the glutes will stay tight and our back will go really flat. So it goes super, super flat. And we're going to have issues with where our head is. We're not really going to know where we want to put our head. So I would like you all to just come into whatever your hip hinge position. I would like you all to tuck your tailbone under actually and just try it. So you can feel it and feel what the release feels like. I'd like you to keep your glutes gripping as you come forward. So you can feel that nice flat back and that restricted bottom. Now I'd like you to feel behind you, and I'd like you to feel where your sit bones are, and I'd like you to open them up. So your sit bones are pushing out behind you. So we're opening through those glutes. Nice. That looks good, Sarah. Rachel, good. Dottie, good. Much better, Melanie. Now you've thought about it. Good. Okay. So they come back up again. So yeah, they were all much better when you thought about where your glutes should be. What happens with people is they hang on as they come into the hip hinge position. And this hip hinge position is an amazing position to get that extension in the glutes. When we extend the glutes, we get a good stretch through the pelvic floor as well, because it connects straight into the pelvic floor. If we hold the glutes tight as we go down, then what happens is we create this tension in the pelvic floor. And this is a perfect opportunity to create more space. The other reason why it's a perfect opportunity to create more space is as we come into the hip hinge position, our femurs roll in the way. And as our femurs, it's not massive, you know, these are all tiny movements. As our femurs roll in the way, our sit bones push out, our ASIS bones move in. So we've got more space to do the apnea breath, and we've got more of a stretch in our pelvic floor. So it's perfect for releasing tight pelvic floors. So a good cue for this to keep everybody in perfect position actually comes from one of my trainers called Kirsty. And she says, and it works, honestly works really well. She says, imagine that you're in your beautiful upright position, everything's lined up. You've got an open drawer behind you. You've got a basket of washing in front of you that you're not going to drop on the floor. Good, so it's going to stay upright. You're going to shut the drawer with your bottom. So really push the drawer with your bottom. That's it. Keep your knees non-bent. Yep, that's it. And then place the hands on the tops of your thighs. So now your chest is in the right position, so it's not curled under. Your bottom should be in the right position. Good. Nice. Oh, much better. I love the way that works. So Hannah, you've got a wee bit of releasing to do in that bum still. Yes, good, good, good. Nice. And release. Okay, so we want to make sure we're not coming into a squat. So our obvious thing when we come into these kind of hip hinge positions is we go into the position for a deadlift before we actually come up with the weights. So we want to make sure that our knees stay soft but not bent. And the reason for that is so that we got that active stretch through the posterior chain. Good, nice. So let's try that again. Now we all know how to find our bottoms. So we can have our washing basket if you want, and our open drawer, and we're just shutting the drawer with our bum, placing the hands on the tops of our thighs, whichever orientation you need. And your eye line should be down towards kind of midway, about a meter in front of you. So we want to make sure we're not got no contraction up the back of our neck, that our neck is nice and long. But weight is forward on the balls of our feet, heels are growing into the floor, head is growing away, shoulders are wide. Then 3 breaths here and your apnea. So Wendy, straighten your knees a little bit. Good. And Candida, put your hands on the tops of your thighs so you've got some support. Perfect, yes. So they can be internally rotated on the tops of your thighs. These look nice. Now 3 nice slow breaths here and your apnea. Hannah, look down towards the floor a little bit more. Good, and Melanie, you can unhinge yourself a little bit. Keep your bottom wide. Yes, that looks more comfortable, good. Nicely done. This pose is called Artemis and it is an unloaded pose. So we've moved from a loaded pose to an unloaded pose. And this pose is one of the ones that most people find they get the most lift in. Not everybody. So if you didn't, don't worry. You know, it's not everybody doesn't always get the lift in this pose. Any questions about this pose, Dorothy?
Unloaded as in why?
So it's the diaphragm. So we talked about this before. So when we're supine, our diaphragm is working just as a breath muscle, not as a postural muscle. When we stand up, our diaphragm is working as a postural muscle. So it's working against gravity. So it's loaded by gravity. When we come into a hip hinge, our diaphragm is no longer completely loaded by gravity. It's being helped by gravity a little. So this is why this is called a unloaded position. If you're working with a population that has hiatus hernias, so they have a hernia in their diaphragm, so their diaphragm comes through, they're rolling or sliding, I never take them into any inverted poses to start with, not even hip hinge. I start them in upright poses so that there's very little opportunity for their stomach to float through into their chest cavity. So we keep them upright to start with. Once they're starting to say, I hardly get reflux anymore, then I take them to the hip hinge because it's the least inverted out of all the poses and it starts to really see how everything's going. And then I give them a period of time. There's loads of people with hiatus hernias, by the way. This will come up more and more the more you now put it in your awareness spectrum. And put them into their hip hinge position. And then when they're saying, I'm not getting any symptoms, then I'll take them to the next position we're going to learn. And we're slowly training the diaphragm more and more to work with the esophagus. So that's one of the main ones that come up with that. So you always want to kind of have a loaded and an unloaded, one after the other in most sessions. We're going to put 2 unloaded together just now though, just because it's for teaching ease, because I want to release the bums some more. So we're going to come down into a quadruped position. And we're going to learn the first quadruped pose, which is called Gaia. Okay. And don't worry, there'll be lots of cues on the sheets that I send out to you. I know there's not that many cues in the ones you've got. So we're coming into a quadruped position. And in this quadruped position, we want to make sure we're bone stacking to start with. So we're going to start with our knees directly underneath our hips and our hands directly underneath our shoulders. I'm going to give you something to do against the wall if you can't be on the floor for this as well. So, and that's just remind me, I forgot to send the video to some other people. I better do that. So from here, I'd like you to, now what we're going to do is make sure that our glutes are wide, and we want to make sure that our rib cage is still an equal distance away from our pelvis all the way around. So quite often when you come into this position, people will automatically glute clench, which will give them a flat back. We're not looking for a flat back, so we want to make sure that the glutes have been extended and we have a nice neutral spine. And the way to do this is to get people to feel their sit bones. And if their sit bones, and then once they've felt their sit bones, then they're going to feel that their sit bones are lighting the way behind them and not lighting towards the floor. They're also not lighting up towards the ceiling. So we're not going into full-on Beyonce. We're just going into a neutral pelvis position. Good, these look nice. Not bad. Okay, so from here, we're going to start the active stretching. So we're going to curl the toes underneath behind us. We're going to feel like we want to press the heels lightly away. And again, it's like a dimmer switch. It's not anything hard or tense. For the majority of people, some people, for internal rotation is too much in this posture, so they can stay with their fingers pointing towards the end of the mat. The full posture here, though, is to turn the fingertips in the way to face each other. And then we pull the shoulder blades together and then press the shoulder blades out towards the side, bending the elbows a little. So it looks like that position we had with our arms already in Athena, but on the floor. Then we want to think about our face. We want our eyes and our face looking straight towards our hands. So we've got a nice long neck. We want to make sure we're not looking up because we don't want that contraction in the neck. We want to feel like our sacrum is pulling the opposite way from the crown of our head. Good, nice. So Sarah, look down towards the floor a little bit more. Good, nice. And Rachel too, look down towards the floor a little bit more. And now to stop us dumping weight into our wrists too much, I'd like you to imagine you're on a boiling hot floor that you can only just touch. Good. Okay, so now from here, tuck your toes under, make sure toes are tucked underneath behind you. We're going to do 3 nice slow breaths and your apnea. So take your time with your breathing. Good, and Hannah, look down towards your hands a little bit more. It feels like quite a strange position. And Melanie, look down towards your hands a little bit more. Yes. And really focus on breathing into the back of your body here. You've got loads of space to breathe into the back in this position. Good. Now, if wrist things are too much for clients as well, you can have the fingers pointing straight ahead. This is also an option. And if they're pointing straight ahead like this, we want to feel almost like we're pulling the hands away from each other to give that activation through the shoulder girdle. So instead of having it like this, where we're thinking about pressing the elbows out towards the side to get that activation, we want to feel like we're pulling the hands away from each other. The other one, if this is too much also for people's wrists, which it can be, is that you can come up onto fists and do it onto fists. In this way, you're no longer going to have your hips and your shoulders in a straight line with each other in the horizontal, but you want to make sure your ribcage and pelvis still stay an even distance away with you, even on their incline. So just being aware that that's what you're looking for, rather than this kind of position. Okay, how did that feel in people's bodies, Gaia? Okay, good. So let's move into Maya. Maya is on our elbows. So we're going from Gaia, so find our box first, and this is important because weird things happen here when we go down any lower. So we want our hands directly underneath our shoulders and our pelvis directly over our knees, and our back of our body is not going to change. Our pelvis is always going to be over our knees. Then replacing one elbow at a time. So I find that it's a much easier way to do this than getting people to just come down. So you're going to take one elbow and place it in line with the other hand, and then the other elbow down. So you've got this nice long back still. Now making sure that you haven't dropped your rib cage. So check, because that's a cue for me more than anybody else. Making sure your rib cage is still an equal distance away from your pelvis. We're then going to take our eyes and move them back towards behind our elbows, towards our knees. So we've got a nice long spine. Now, I'd like you to think about that boiling hot floor you're pulling your body away from. And I'd like you to feel like you're pulling your arms slightly away from each other as well. Just a little light activation. Heels pressing away, sacrum pulling one way, head pulling the other. 3 nice slow breaths and an apnea here. Candida, that looks great. So just your eyes. Good. Three breaths here and your apnea. Nice and slowly. Good breathing. That apnea was pretty good, Candida, by the way.
Sorry, I'm actually looking at myself in the mirror to see whether I'm moving.
It was, yeah, no, it was a good apnea. It was a good apnea. I think worry less about it, feel it more.
Yeah, definitely.
Like, seriously, it looked nice.
Yeah, definitely better.
Yeah, yeah, yeah.
Can I just a quick question? What's the ideal time when you've started your kind of holding your breath to kind of trying to expand?
So you're wanting to expand to the same diameter that you can inhale to ultimately. You don't want to expand over that. We're not looking to strain the rib cage. So we're looking to take it to where you would naturally go if you're taking a really deep, long inhale in. So we're not looking to push it any further than that because we don't want to strain the intercostals.
Sorry, no, what I meant was once you've exhaled and then you're sort of starting your kind of apnea, so to speak, do you start that expansion straight away?
I get people to pause for a moment, and there's a couple of reasons for the pause. One, to make sure you close your mouth and nose. One, to make sure that you've got a little moment to release your abdominals if you need to. And two, so that was lots of ones. Two, to disassociate the opening of the rib cage with the taking the breath in. And for a lot of clients, this is a massive habit to break because the minute they start to widen their rib cage, they sneak air in through their nose. And then what happens is instead of taking an inhale at the end, they exhale. And that's something for you to watch out for too, because the exhale will be a good giveaway that they've snuck air in. And it just takes practice, it just takes practice. And also feeling comfortable. A lot of people will have had lifetime things that have happened to them, like perhaps being suffocated by their older brother when he was playing. Perhaps they've had a near drowning incident. Perhaps they've had something happen to them that was really traumatic to do with their neck or their face. And sometimes for these people, it takes a long time to feel comfortable, which is why I now always start teaching the apnea with that rest relaxation exercise we did at the beginning, where we do the 3 breaths and then we pause, not bringing in any air, not doing any apnea, and just be as chilled as possible with the space between breaths. And this is really important because if you get clients that cannot hold that space at all, there's probably a reason for that, and you need to work through that with them. And I don't talk to them about it. I just make sure that we work with their breath until they feel comfortable. Sometimes talking about trauma re-traumatizes, and I'm not a counsellor, so if I feel they really need that, I will ask them to go and see a counsellor about it, or talking therapy or some other therapy. I'm training to do tension release TRE just now so that I can deal with that, but again, not in a talky way, in a body way. Again, just be aware that people will come to you with all sorts of things. And sometimes you can really see it when they're doing their apnea. I've got a small child incoming, so I'm just warning you now before we move into our sitting pose. I can see him. He's like looking through the door, trying to work out what to do. Give me 1 second. What is that? I don't have your controller. You'll have to look in the house. Okay. I actually haven't nicked his controller for once, so that's quite good. I'm just checking. No, I haven't. Okay, so he's really addicted to this horrible game. So sometimes I nick his controller, so he can't do it. So we're going to come to sitting now. So Hestia, we're going to come back to Hestia again, and we're going to revisit it, and then we're going to revisit all the poses all the way through, so we can just work through them together in our little flow. So Hestia has 3 leg positions, but it can also be performed on a football or a chair, depending on your client. So it doesn't have to be done sat cross-legged or anything like that. If they're sitting on a chair, they need to make sure that their knees are in line with their hips. So the chair that I showed you earlier would not be a great choice unless they had blocks underneath their feet, because we want to make sure the hips are in line with their, and same if they're on a Fitball. If they're on a chair, they're going to keep their feet flat on the floor, because I really want them to think about that alignment from the sacrum all the way up to the crown of the head when they're working with it, rather than trying to think about things for dorsiflexion and things to start with. And they're already doing lots of activation and sitting. So that's the thing. It can also be done in a wheelchair. So I've done lots of work with MS people, the MS client base, and it can also be done in a wheelchair. Happy days, so we can still do it. The 3 leg positions if you're on the floor. You can sit on a block if you need to as well. So making sure that people are aware that it's just tight hip flexors. It doesn't mean they're rubbish at sitting, so that they're not embarrassed to use a block. So we can sit cross-legged. So if you're sitting cross-legged, I like to make sure people change regularly which side their legs are crossing on as well. If you're sitting cross-legged, you're going to sit with your feet dorsiflexed. So we've got the ankles still dorsiflexed for that active engagement. We're going to sit right on our sit bones, and we're going to make sure that our rib cage is directly over our pelvis. So for this, again, it's really nice if you're in a room with somebody, because you can stand behind them and just check that they're not leaning forward and they're not rolling back in their sacrum. So quite often when I teach online, I get people to sit sideways on to start with, and then I look at them face to face. The arm positions are all going to be the same. Just making sure that the head, the chin is horizontal to the floor and eyes are looking straight ahead and they're soft. The reason for soft eyes is this. Our eyes are the first things that apart from our neuroception, our eyes are the first thing that identify danger or fear. So we're imprinted with this thing that if we have tension in our eyes, it sends a message through this cool network at the back of our eyes to our grey matter, to our amygdala, and then to our pons, saying that we're frightened and that there's a fearful thing happening. It sends an electrical impulse from the pons at the back of our brain down our spine to S1, S2, where there's a cool little nucleus called the Onuf's nucleus, O-N-U-F, if you're a nerd like me. And then from there, our body sends a message to our pelvic floor, whether it is safe to defecate or not. And these messages can be mixed up. So it's like our social gauge. So this, when we're training kids to toilet train, this is what we're training. We're training this idea that, this is not socially acceptable now is socially acceptable. So this happens all within our nervous system. And that's why women who have really mobile pelvises during pregnancy, sometimes this can get, the nerves here can be affected, because it really does sit, usually with most people, between S1 and S2. And it is like a little, PowerPoint, not PowerPoint, yeah, like game console thing. And it sends these messages out. So making sure when we come to sitting that we're sitting right on our sit bones, rib cage is directly over our pelvis, we're not rolling back in our pelvis, and we've got our sit bones. So that's the first leg position. Second leg position is to have our legs out in front of us, hip distance apart, and with our feet dorsiflexed and our knees slightly bent. I know I'm like wearing the wrong color of trousers for these mats today. So we don't want them straight out, and we don't want to have our heels popping off the floor. We don't want them all the way up here either. We want them so that they're a comfortable distance with a comfortable bend in them. When we're sitting like this, same thing, sit right on your sit bones, rib cage over your pelvis. But this time, instead of just dorsiflexing our feet, because I'm going to give you something else to do cross-legged in a minute, we're going to squish our marshmallows and we're going to pull our heels back gently towards our sit bones with no movement. So you should feel that activation right into your pelvic floor. The third position is to bring your knees together and your feet together, and then press your knees out towards the side, keeping your heels together and your feet dorsiflexed. You're still drawing the heels back towards you. You're doing less squishing of the marshmallows. And here again, we're getting, this is nice for people who find it really tight in the hip flexors, nice position. Okay, if you're sitting cross-legged, the extra activation is this. Once you dorsiflex, you want to feel like you're at the moment just before you're going to uncross your legs. So you've got this little extra activation. And I don't always cue this with people because there's too many cues sometimes. But once they've been doing it for a while, I give them this little other activation. And what that does is you can feel it activating up through to your adductors. Okay, so now here, we're going to choose this moment to do a visualization. So picking the leg position you like the most.
Rib cage in position, chin horizontal to the floor, eyes can be partially closed if you like. I would like you to visualize the whole of your pelvis, the distance between the sit bones, the distance between the coccyx and the pubic symphysis, the distance between the ASIS bones. As we inhale, I would like you to start thinking, first of all, like it's a bud. That whole area is a rosebud. And as you inhale, I'd like you to think about the rose petals bursting out the bud. As you exhale, I'd like you to think about the rose petals gently closing, but they cannot go back into the bud because it's not possible. So there's this gentle closing of the petals for nighttime. Inhale the widening of the petals, exhaling the gentle closing. And we're going to do 3 of these breaths and then pause and do your apnea. So take your time, nice and slowly. Victoria, if it's more comfortable for you on the floor lying down, you can lie on your back and do this visualization, you know? Yeah.
Going to the sofa. I'm just going to watch.
Yeah, it's totally fine. So this is a great place for us to connect to our pelvic floor and our pelvic area. A lot of women feel a total dissociation between this part of their body and that part of their body. This feels like them, this definitely doesn't. And we want it to be something nice. And so giving a pretty visualization like a rose is a nice way to do it. But my ladies come up with all sorts of different things. So you can think about an eye opening and gently closing. You can come up with your own one, the ocean going out and coming back in. I have one lady who thinks about an octopus tentacles coming out and going back in. Whatever floats your boat, as long as you can feel that kind of release and then drawing back in gently. That's what we're looking for. So we're thinking about that coming back to a gentle resting tone, never back to tension. And this is another way to work on that, having too tight a pelvic floor. And I like to use this at the beginning of classes and sometimes just halfway through, throw it in for a little bit of like excitement. So now you've got that armed with that. Oh, that's what I was going to tell you. I used to tell people that when they're in the sitting position to think about their sit bones widening and then drawing back in. I don't do this anymore, even though it's actually quite a nice visualization, as long as you understand that the sit bones move millimeters, like not even millimeters, smaller than millimeters. You know, the movement is tiny. Because I had so many women saying, I really can't make my sit bones widen and close. I was like, no, don't do that. So you can have that visualization too. If you can tune into the, as your rib cage widens, the bones of your pelvic floor open and close. If you've got your lovely ball next to you, you can actually use your ball for a bit of an embodiment exercise too, which is completely nicked from Eric Franklin. So you can hold your ball in front of you, and as you inhale, you release the ball. And as you inhale and release the ball, and then as you exhale, you squeeze the ball. And you will actually feel this in your pelvic floor. If you don't have a ball, you can pretend you've got a light force in front of you. So you can think about there being an orb of light, I quite like this one, or a magnet if you prefer. And so as you inhale, the orb of light gets bigger, and as you exhale, you're squishing it closed and tighter. So that it's the action of the hands moving. The ball is a great prop. But I quite like the ball of light for being superheroes. So inhale and then squeezing back shut. You can actually feel your pelvic floor move when you embody it from the outside. So it's a lovely exercise to do with people. It's one of my favorites actually. It's also across, it's in Franklin for pelvic floor, it's in the Mutu method, it's in Lauren O'Hyan, it's in almost every method, this embodiment of the hands to the pelvic floor in a sitting position. So just, I mean, it is everywhere. I have, you know, adopted it, so to speak. So then what we're going to do is, now we've thought about all these lovely visualizations, we're going to do a pose here, and then we're going to run through everything. So we're just going to choose one arm position. So I'd like you to choose your favorite arm position. If it's internally rotated, brilliant. If it's out towards the side, brilliant. If it's up here, ace. If it's up here, you're thinking about the stretch from the opposite glute up towards here. So find your favorite one before we run through all of them. Think about, find your favorite leg position, make sure you're dorsiflexed. If you're out in front of you, squish your marshmallows, draw your feet back. If you're in your diamond position, make sure that you've got that connection with the feet drawing back. Make sure your head, think about that, listening to the conversation behind you. 3 nice slow breaths in your apnea. And if you want to do the visualization for your pelvis as you do it, then please do. Make sure eyes are gazing straight ahead, or eyes are you can have eyes closed as long as eyes are still gazing straight ahead, so to speak. Make sure we're not looking down. Good. And take your time with this, nice and slowly. Done a lot of apneas today, guys, way more than people usually do, so you'll be getting tired. So what we're going to do is we're also running out of time as well. We're going to run from the top to the bottom, but we're only going to do 1 breath and apnea in each pose, just so you get a feel for a little bit of a flow. I'm going to count you so we keep all together, and I'm going to do 3 and 6 for our breathing, and I'm going to do a pause, hopefully of 8, because I know that you're tired now. So I'll do a pause and apnea breath for a count of 8. And then we've got time to chat at the end. So we're going to come up to standing and start standing, and we're going to end up lying down because it's always the best way to go for most people. So we're starting with our feet hip distance apart, knees are soft, feet are in a straight line with each other. Neutral pelvis, you can think torch, rib cage directly on top of your pelvis, shoulders up towards your ears and then drop them down. Gazing towards your horizon, chin horizontal to the floor, listening to your conversation behind you, roots growing in from your heels, head growing towards the ceiling, shifting your balance forward but keeping that even weight, stretching your hands out towards the side, palms face forwards in a downwards V. Ready to inhale. In, 2, 3, out, 5, 4, 3, 2, 1. In, 2, 3, out, 5, 4, 3, 2, 1. In, 2, 3, out, 5, 4, 3, 2, 1. Close your mouth and nose, pause, widen your ribs for 8, 7, 6, 5, 4, 3, 2, 1. In, 2, 3, hip hinge, 5, 4, 3, 2, 1. Make sure your weight's forward, 2, 3, and your toes are soft, 5, 4, 3, 2, 1. In, 2, 3, lengthen through the back, 5, 4, 3, 2, 1. Close your mouth and nose, pause, widen your ribs for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. In, 2, 3, step back with your left, 5, 4, 3, 2, 1, coming to the floor. In, 2, 3, right leg, 5, 4, 3, 2, 1. Hands down in front of you into your Gaia position, 2, 3, out, 5, 4, 3, 2, 1. Close your mouth and nose, toes tucked under behind you, and slowly widen your ribs for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. In, 2, 3, replace your hands with your elbows. 5, 4, 3, 2, 1. Check your eyes are looking back towards your knees. 2, 3, press your heels away. 5, 4, 3, 2, 1. Lengthen from your sacrum to your head. 2, 3, out. 5, 4, 3, 2, 1. Close your mouth and nose. Pause. Widen your ribs for 8, 7, 6, 5, 4, 3, 2, 1. Inhaling here and exhaling, coming into your choice of sitting position. There's a cool transition I'll teach you in the next one. So I've got to try and fit everything in. So finding your sitting position, this time we're going to take our hands to a high V. We want to feel that length from the sit bones all the way up through. Ready to inhale. In, 2, 3, out, 5, 4, 3, 2, 1. In, 2, 3, out, 5, 4, 3, 2, 1. In, 2, 3, out. 5, 4, 3, 2, 1. Close your mouth and nose. Pause. Widen your ribs for 8, 7, 6, 5, 4, 3, 2, 1. Inhaling here, exhaling. If your legs are crossed, extending them out, putting one elbow down towards the floor, rolling yourself towards the floor, dorsiflexing your feet. Legs are hip distance apart. Take a moment to find your neutral pelvis, ribcage heavy, back of your head heavy on the floor. Taking your hands internally rotated into second. So palms face up, rotate the wrist, the elbow, the shoulder, extend the wrists and bend your elbows. Straight across your body. Nice. Ready to inhale. In, 2, 3, out. 5, 4, 3, 2, 1. In, 2, 3, out. 5, 4, 3, 2, 1. In, 2, 3, out. 5, 4, 3, 2, 1. Close your mouth and nose. Pause. Widen your ribs for as long as you can. Take your time, nice and slowly. Get the nicest, widest rib cage opening you've managed today. And when you need to inhale, you're going to inhale here and exhale, release and shake your hands off. Good. Okay, everybody. How are you all feeling? Where's my ball gone? My ball for sitting on. Ball.
That was great. It was so lovely to get the feeling of a flow with it.
Yeah, the classes are all really like that, you know, so there's a couple more poses as well, which we'll learn in the next bit if you're coming to join me, which complete the flow for sequence 1. There's too many to fit in today. Always, there's so many. I'm glad you enjoyed the flow. The flow is the bit, you know, actually getting that rhythm and getting the rhythm of the breathing and moving from one to the other is what's really helping the nervous system as well. And it's also helping the activation of the fascia, the activation of the muscle chains. The flow is everything, really. But to start with, it can feel quite staccato while we're learning, you know.
Abby, how long would you take to, say if you were doing this with a new class of people, how long would you take to progress into that kind of flow? Would you spend, say if you're doing like a 6-week course, would you spend the first week just learning, you know, the basics and then progress and then end that with the whole flow? Or would you start to bring them into that flow fairly soon? How do you play it with your clients?
So I start, the first session is always about breath and about the supine pose. And if everybody is going really great with the breath and the apnea, then we'll move into doing another pose. So the first class will really be about breath, breathing, assessment, first pose supine, the Demeter pose, and then I'll pick either the sitting pose, because I know everybody loves it, or one of the other ones to teach them. The second session, I'll start to talk about loaded and unloaded a little bit, and we'll look at doing the quadruped poses and usually the standing pose as well. So I'll start to build it in. And by session 5, we would be doing a whole sequence flow. So I build it really slowly in, but I kind of try and make it into a mini flow while we're doing it. So we didn't do aura pose today, but quite often what I'll do is teach them the Demeter pose, the sitting pose, then the quadruped poses, and we'll mix them as a little mini flow by week 2. And then I'll add the aura pose and we'll mix a little mini flow that goes from upright kneeling to quadruped to sitting to supine. And then I'll bring in the standing ones in the next week. So we slowly, so there's little mini kind of flows in amongst the learning, you know. But I also bring in movement really early. So if you're coming to the next session, I bring in a lot of rocking and things right at the beginning. Because it's so good for our nervous system, and it's also really good for our bodies, for learning our posture patterns better. Yeah. Yes, Dorothy.
The number of breaths in between the apneas, is it always 3 because we are habituating our nervous system to it, or why is it always 3?
So it's always 3 when I'm working with the cohort I work with, which is about creating functional pelvic floors. And the reason is to give us enough residual oxygen in the body to be able to form a lovely calm apnea. It's also to calm the nervous system down. Yes, we're talking to the nervous system. You can, if you're working with athletes, you can change the breath cycles. So instead of having 3 breaths in between, so once a person can reach 3 breaths and hold their apnea, or use the pause for 12 to 15 seconds, you can take a breath away. And what that will do is reduce the residual oxygen when they go to do the apnea the next time. So then instead they have 2 breaths in between and then the apnea. And once they can maintain an apnea again for 12 to 15 seconds, then you can take the other breath away. So we've got 1 breath between the apneas, and then we take that up to 12, 15, and then that's where it stays. 1 breath, apnea, 1 breath, apnea. This I use and have used for my clients who are training for a big competition, because what it does is it improves their sports stamina, improves their CO2 tolerance, and makes everything much easier for recovery, and just for endurance as well. But but it also heightens the nervous system. You know, you've got less calming of the nervous system. There's more heightened feeling within the nervous system. You can also reduce the amount of time you breathe. So instead of doing 3 and 6, you can do 2 and 4. But I tend to try and keep people to the slightly longer breath and just reduce the breaths. So we do have some nervous system regulation in there, you know. But yeah, my CrossFitters are mad for me reducing their breaths. I'm like, you can't even open your rib cage yet. Why would we do any of that? You know, because they've got such tight abdominals that they can't. I mean, the people who find it the hardest almost to open their rib cage are if we've really overtrained the abdominals so that we can't actually move our rib cage anymore, which comes up quite a lot with my CrossFit crew. I love CrossFit too, but you know, not as much as some of them. You know, yeah.
How much are you looking? So obviously you want to practice it. How much would you be doing? How long would your sessions be? How much would you practice? And how, I know everybody's different, but when can you expect to see a change if it's with your pelvic floor?
So the first session, if I'm seeing somebody one-to-one, the first session is an hour, a full hour. After that, they can either, usually I encourage them to do 2 to 3 1-hour sessions with me before they enter my online classes or practice on their own. So I do encourage them to do that, although it's a cost thing. So quite often I try and get as much information into the first hour, and then they can join my online classes and get more tuition that way, which is much more cost effective for people. But generally, what we're looking for people to do is be able to practice for 10 minutes a day consistently. So 10 minutes a day, every day, except one day that they have off where they don't think about their pelvic floor at all. They can do a crossword or something instead. No pelvic floor thoughts on one day of the week. I don't want any obsession. So 10 minutes a day is all we're looking for. And I know everybody says 10 minutes a day, so something that's 10 minutes a day become like 1,000,000 minutes a day. For improvement, it really depends on people's bodies. But if we think about when you go to a gym and you start training fast twitch muscles like your biceps, we're looking at, from a personal training point of view, I'm looking for between 3 and 6 months to really be seeing a visible change. You know, everything up to then is like almost like the preparation. We're working with slow twitch muscles. So for the majority of people, they do start to see a progressive change between 3 to 6 months, but it can take longer. But they do see progression. You know, it's things like my stress incontinence went almost immediately. The feeling of a tampon was about 6 months before the feeling that a tampon was falling out went. But everybody is slightly different. But it is a slow, gradual change. It's not like suddenly one day you go, hey, my prolapse is gone. It'll be something that one day you think, I have not thought about it for a month. And that's when you realize that it's happened, you know. And it's also not linear. So that's the other thing I really explain to people, that hormones happen, life happens, stress happens, grief happens, things happen in your life that will really affect your pelvic floor. So you may be going along in a plateau like this and something will hit you that you weren't aware of. It might be perimenopause, it might be, you know, so many different things it can be. And you'll feel like you've gone back to ground zero. And it happened to me a couple of times and I was totally distressed. But I've got great friends who are like, hey, Abby, you did it before. Do it again, do your thing. Slowly you get fewer peaks and troughs and it's more of a straight line towards the end. But I do have some clients, honestly, Rachel, they come and do one session with me and they're like, oh, honestly, I had a review yesterday from a woman who's just like, oh my God, you saved my life in that session. And we've done 1 hour session and she's just she just feels like everything's back in place. And it just depends. Like Dorothy and me, with my really weird hypermobility in weird places in my body, it might take me longer. I've got a really hypermobile pelvic floor, so it took me longer, you know, and it depends on connective tissue, age, genetics, so many other things. But I do try and give people a ballpark figure. I say, you know, within 6 months, you should be noticing differences in your body. But you should have already noticed them. I mean, people notice their waist gets thinner, their abs get a little bit more toned, that people comment on their posture, loads of comments on posture. They feel breath is easier, life is easier, you know, things like that. Lifestyle things change before the pelvic floor thing changes. Yeah. Sorry, I wish I could just go in 8 weeks. It really annoys me actually when people go online and they say, if you do this program in 8 weeks, your pelvic floor will be fixed. There's just no danger that that's happening, because it is, you know, yeah, it just annoys me. So I try to make it really realistic for people that this is an ongoing process, and for some people, my rectoseal took 18 months to 2 years to change grade. And some people it might take longer, and some people much less.
Abby, what
Yeah.
about if I'm helping my 75-year-old lady who's just had her rectocell surgery? What approach do I take? I think it's just going to be breathing for her because she's got very tight rib cage.
Yes, so definitely if she's just had the surgery, breathing only, and postures, definitely. She can use postures, but with the breath, and learn the breath. With any surgery, we want to give the fascia and tissues a good 12 weeks to settle and be good again, be progressing towards healing. So fascia and connective tissue and scar tissue and things as well. And I would also be encouraging her to try and find somebody who does scar tissue release, because there will be loads of scar tissue. So trying to find something, you know, I did that because it's like the anus, scar tissue release. So I would definitely be encouraging her to try and find somebody who could do some scar tissue release, because it releases the stuck fascia and can make a massive difference when it comes to recovery from surgery and childbirth, actually. If anybody's had kids, you know, at any time post-childbirth, get some scar tissue release. Yeah. Start her slowly and just, build her into it. But it's really good for helping maintain surgery if you've had it done, because surgery has such a high failure rate, and it also has a time limit. So it's 8 to 10 years. So she needs to make sure she can maintain it for the full 10. Okay. Any other questions? Dorothy? Oh, you're muted.
I was just saying, yes, me again. I know I will be asked this question, and maybe it's for course 2, or maybe I should never ask it, but I know I'll get it. So is part of this at all, will it ever happen that you add activating the pelvic floor to this work? Is it at all within this regime or within this thinking?
No, and the reason is this. If you create a tension or activation in your pelvic floor as you're doing the rib opening, what you're doing is you're creating a tension at the bottom of the stretch. So if you imagine that you've got so we've got this beautiful stretch that's going through our body like this, but instead of it being allowed to stretch, we then put a weight on the bottom of it. So we create tension, a real tension on the bottom, and then we try and lift. We're not going to get that same natural lift through the body. We're looking to create long chains of movement. If we create tension in the middle of that long chain, then that stops the fluid movement of that long chain. So if people want to do Kegels, what I say to them is do them separate from this. You know, you don't need to do millions of Kegels anyway. You know, it takes you 5 minutes. You do 10 quick ones, 10 slow ones, and go up and down the lift. Like 1, 2, 3, 1, 2, 3 down. That's you're done for the day. You should never do more than that. I have so many clients who get told by doctors and gynecologists to do 50, 4 times a day or whatever. It's just, you wouldn't work your biceps like that. Why work your pelvic floor like that? So yeah,